Good morning, everyone. Thank you for joining us today. Today, the Upper Midwest Telehealth Resource Center, will be presenting a variety of information in cooperation with the Ohio State Office of Rural Health, and we'd like to give a special thanks to Shane Ford for arranging all of this information today. My name is Becky Sanders, and I am the Program Director for the Upper Midwest Telehealth Resource Center. Hopefully you all have the agenda for today. If you do not, it's available on our website. And also, if you can, go ahead and use the chat function, chat to Carolyn Miller, and she can make sure you get a copy of today's agenda. We're going to go right through the day. We are going to take 1 hour break for lunch, but other than that, we do not have any scheduled breaks. The platform that we're using today, the Zoom webinar platform, everyone is in listen-only mode. So we encourage you, if you have questions throughout the day, to use the Q&A function to ask your questions. The chat function only for technical issues. We will stop at the end of each presentation for an opportunity for Q&A before we move on to the next topic. Trying to think what else. We are recording today's sessions. They will be available in about a week or so on our YouTube page, and the slides will be available with each individual session on our archived webinars page. I think that should be all of our housekeeping, and we've got several speakers today, so as the different speakers come up, we'll introduce them individually. And again, thank you for joining us today. Our first speaker today is Miss Allie Orwig, and she, like myself, is an employee of the Indiana Rural Health Association. And she is going to talk to us. She's got two topics this morning. Actually, I'm sorry, I'm first. I'm jumping ahead. So I'm going to start us off with the intro to telehealth and some virtual care basics. Then we'll hear from my colleague Allie Orwig about broadband and community health needs assessments. So let me go ahead and share my slides. And so with so many things have happened over the past 14 months with the COVID-19 pandemic and all the public health emergencies. Later on today, we're going to talk a little bit about policy, and Nichole Small from the Ohio Medicaid portion of the Department of Health in Ohio will be talking specifically about Ohio Medicaid changes due to COVID. I will talk later a little bit about Medicare at a very high level. Policy and reimbursement is one of the things that changes most often, and we've seen tons and tons of changes in the last 14 months. So while some of this intro to telehealth may be kind of old news to you, I did want to make sure that we started the day on the same page. So that's why I am including a little bit of intro to telehealth before we really jump into topics today. So the basic definition, and today it's the terminology has changed. Telemedicine used to be the term that was used the most to describe that clinical encounter between a patient and a provider, and that's a billable event. And then really the term telehealth really became more the overarching field of using virtual platforms to communicate education, to give classes, diabetic counseling, those types of things come to mind, or even what we're doing today over a virtual platform. But then we'll also talk about some other terms that have come into play more recently. And it's just as the field of telehealth and telemedicine evolves, the terminology is changing. Also with COVID, so many more people are aware of telehealth and have participated in telehealth events that the public is becoming much more well-versed and they're using terms like virtual visit or virtual care. So we're seeing a change in terminology. So types of telehealth. So when we talk about telehealth, generally we're talking about synchronous telehealth. This is the most common, most commonly reimbursed by Medicare, Medicaid, and private insurance companies. So this is kind of like a two-way walkie-talkie where we can see and hear each other and talk over each other if we're not careful and respectful. But this, when we talk about telehealth, really we want this to be a HIPAA compliant platform. We'll talk about some of the HIPAA waivers that have happened over COVID, but now that we're 14 months into this, we definitely expect that everyone has moved to a HIPAA compliant platform. Then asynchronous is what we call store and forward telemedicine. This is most often used with labs or in dermatology where you're taking pictures of a rash or a wound or something like that to be read at a distance and then come back. And this typically is not reimbursed as a telemedicine or telehealth event. So I also want to stress that telehealth is not a service in and of itself. It is a delivery mechanism. We're using technology to deliver the same quality patient care as if the patient and the provider were in person with each other. So I told you we'd talk more about terms. So additional terms that have been around the industry, mHealth, and that really is talking about, it's hard to see me with my background, mobile health, using tablets or smartphones for the delivery of a virtual platform, e-health, electronic health, health over the internet, and virtual health. So today you'll probably hear me use all of these terms interchangeably between virtual care and virtual visits and then virtual health is the umbrella over those two terms. Telehealth as the overarching term of all of these different categories. And then today there are so many apps out there that you can download on your smartphone, you can download on your tablet, on your computer, on your laptop. The number of healthcare apps changes every day as new apps are added. And then we all have, there's wearable fitness devices to track our steps or our heart rate or our blood pressure in some cases. So there's a lot of ways that we can gather as patients. If we think about ourselves as patients, we can gather our own health data and sometimes use that when we're in a virtual visit from home with our provider. So just setting the stage. So this next slide is a history of telehealth. And I have to give kudos to our intern that has left us, Joe Orwig, for creating this for us. You can argue all the way back in 500 BC that Greeks and Romans used smoke signals to deliver healthcare information because they would send signals if there was a plague or storms or other things between communities. In the early 1900s, the magazine Radio News became very popular, and they actually had a international convention talking about delivering healthcare over radio waves or using a television to deliver healthcare. And what is a computer monitor except a television that's only using the information from the computer? And with all these Netflix and Hulu and Amazon Prime, and I'm going to forget a bunch of others, what do? We watch TV on our computer monitors. So it's kind of interesting, almost 100 years later. Here in the United States, telehealth really took hold around the 1950s and 60s when we were first sending man to the moon. And the ARPANET and the history of the internet, if you're familiar with that, universities and NASA and other government entities got involved. And then the creation of the internet in the mid-80s. But there's a couple of individuals that I do want to to notice or to mention in the history of telehealth for our country. Dr. Jay Sanders is on this screen, and Dr. Rashid Bashar. Dr. Jay Sanders was located over on the East Coast and doing telemedicine from one hospital to another hospital across the Hudson River. And Dr. Rashid Bashar is still a professor at the University of Michigan. Also in Ohio, and we ran out of space, so we didn't get him on there, but with NASA, Dr. Charles Dorn, or Chuck Dorn, with the University of Cincinnati, has been extremely knowledgeable in this field and a champion of telehealth in our region. It wasn't until the late 1990s, I think it was 1995 or 97, that the Medicare, CMS, Medicare started reimbursing for telehealth. Also, you see here, 1993, the American Telemedicine Association was founded. So it really wasn't until in the 2000s and 2010 forward, and then with COVID in 2020, it really pushed policy forward about 20 years. It wasn't until 2019 that all state Medicaid programs paid for some form of telehealth or telemedicine or both. All right, so let's talk a little bit about modalities. So from the 50s, when telemedicine was first invented and actually started working, we were in these situations where clinical telemedicine was a business-to-business arrangement. So one small critical access hospital, maybe in the emergency room, to a trauma center in an urban community, or as we started evolving, a rural health clinic to a critical access hospital, or a primary care clinic to a behavioral health specialist. But those were all business-to-business transactions, really, when you think about it. So a patient in a clinical setting to a provider in a different clinical setting at a different location. But with the advent of COVID, we started to see patients at home, and we saw all the waivers that we'll talk about later for the patient and even the provider to be at home because of the shutdowns that happened last spring. So we really moved more from a business-to-business transaction or modality for telehealth to a business-to-consumer or a business-to-patient modality. And as we go through the day, and specifically in our reimbursement sections, Nichole and I will talk about Medicare changes, Medicaid changes for Ohio, and private payer changes that have occurred in the last year or so. So when you talk about what populations can benefit from telehealth, basically it's anybody. Anybody from students, even in babies at home. I wish when I was a parent, when my 10-year-old and 15-year-old were babies, that I could have had access to a pediatrician at 2 o'clock in the morning when they're screaming for no reason. That would have been wonderful. But generally, all populations can benefit from some form of telehealth or telemedicine. When we talk about specific disciplines, I talked about a little bit about the origins of telehealth in our country, and hospitals and specialties was really the origin of telehealth in our country. And then I mentioned primary care and behavioral health, and that integrated care started taking hold in the 2005 to 2010, 2015 timeframe. And a lot of that happened between 2010 and 2015 with the advent of healthcare changes and CMS trying to create new programs, new innovative ways of taking care of our population with different primary care medical home focus, or with the accountable care organizations and just to the different change and thought modality into population health and those types of things. And then we got into transitions and monitoring. It was, I think, 2012 when CMS first introduced telehealth billing codes for chronic care management, and then remote patient monitoring, and the community paramedicine, which is still kind of individual in the way it is reimbursed for the most part. So we're starting to take care of our patients to keep them out of the hospital. And that was kind of part of the accountable care organizations and some of the bundled payment structures that came in place, and the Medicare reduction in reimbursement if a patient came back into the hospital within 30 days for the same diagnoses. And then primary care in schools has been growing exponentially over the last 10 years. There are several school programs in just about any state, and there's multiple states that have programs that we can connect you with if you're interested in something like that. All right, so benefits of telehealth for different organizations. And again, some of these come from the Accountable Care Organization guidelines and thought processes. What we've seen the most during COVID is a reduction in a reduction in no-shows. So the 30-day readmissions again comes from some of the bundled payment structures in the early 2010, 2012 timeframe, 2015. But the biggest savings that you can track is that reduction in no-shows and also mileage. And so you can track the carbon footprint there. Your patient's mileage that they save from being seen at home or in a local clinic instead of going to an urban facility. Also your provider mileage saved. If you've got a provider that's a specialist and often does rural rotations at rural hospitals. Efficiencies, those lower no-show rates is higher patient throughput, which based on the way healthcare is reimbursed in the United States currently, that means that you're generating more revenue. Providers are not driving to remote locations. They don't have that windshield time that's not productive. And patients driving less means a lot less carbon footprint. And tracking increased revenues. When you are able to keep your patient in a local healthcare system, or the x-rays, the labs that might need to be done as follow-up to a visit, you're keeping that financial transaction within your local economy. And when you think about your local economy, either the top employer 9 times out of 10 is either going to be your school system or the healthcare system in your local area. So you're keeping that revenue local to help pay those employees that are part of either the school system or the healthcare system in your local area. Also, more in a non-COVID environment, but I think it's opening up across the country, is if you have a patient that you are able to keep local and they're an inpatient, then those family and friends that want to visit that patient, it's easier for them to be able to visit their loved one in the hospital. So for consumers, if we turn the tables and we think about ourselves just as consumers, telehealth is going to reduce those healthcare costs, increase our access to healthcare, and it'll help improve outcomes. And the story that I love to tell, thinking about this from a consumer perspective, is in a school-based environment. And say that you've got a kiddo that is at school and has an earache. The kiddo goes down to the school nurse, and the school nurse takes a look, determines, yeah, earache, so probably needs to be seen by a pediatrician or nurse practitioner or physician assistant. If that school has adopted a school-based telemedicine program or a school-based telehealth program, then they are able to connect with a remote provider. They could even have the parent come in physically to the office at the school or on the virtual platform and participate in that clinical session. The provider looks in the ear with a digital, well, actually the nurse is going to have a digital otoscope to put in the patient's ear, in the kiddo's ear. The provider at a distance can see that over a virtual platform and diagnose, yes, there's redness in the ear. Oh, yes, it does look like there's an infection. Okay, the provider goes ahead and creates a prescription. And in some cases, some schools have worked out relationships with local pharmacies. That kiddo could have that antibiotic on board that day, and the parent doesn't have to take off work. The kiddo doesn't have to miss school. And even more importantly, the kiddo's ear's not going to get worse and worse and worse until the parent finally takes them to the ER with a burst eardrum. So in that situation, you're taking it's a lower healthcare cost because you're talking about a primary care visit that might run $150 versus an emergency room visit that might run $1,500. There's just one example. Allie's going to talk a little bit more about broadband, but I have to mention that with broadband, it is the foundation for your program. And without strong broadband, your program will be washed away, will not be financially sustainable. And I am going to stay away from these slides. I can't remember why I decided to include them, but I don't want to steal Allie's thunder. So some technology limitations for telehealth. And Allie will talk a little bit about this. There are some new programs around for this. But what we found, especially over the last 14 months with COVID, is that there is a huge digital divide in our country, that there are many people, while broadband is better than it was 5 years ago, extremely better than it was 10 years ago, there are still rural areas where residents in our country, in our states, in our country, do not have access to internet at home. So when the kiddos got sent home from school because of COVID and they had to do e-learning, they either didn't have access to stable internet access or wasn't affordable, or they didn't have access to technology devices. So there's several programs, and Allie will talk about those in more detail, to help bridge that gap. Those are some of the organizations Allie will talk about, and I'm going to go ahead and stop now. We've got about 5 minutes for questions before we jump into the next presentation. Carolyn, any questions?
I do not see any.
Okay. I want to take just a minute, and I'll kind of see if anybody out there is awake. With everything that has happened with COVID, I'm curious to see how many of you out there have either participated in a telehealth event yourself or helped a family member, a child or a parent, to have a telehealth visit. And go ahead and put those in the chat if you would, please. I can say that I have to answer yes to all three. I have had a telehealth visit during the past year with one of my providers, and I have helped my children to have telehealth visits, and I've helped my parents to have telehealth visits. One of the things that's interesting about the evolution of telehealth in our country, do we really only have one person on this call that has had a telehealth encounter in the last year? I find that surprising. Okay, here we go. When you look at the last year, we'll look at some slides later, there's been a 4,000% increase in telehealth visits over the last year. I actually did participate in a telehealth visit prior to COVID, but it wasn't my provider. I would much rather be able to see my own provider via telehealth or in person than see a stranger over telehealth. And that's kind of, it's interesting because I talked a little bit about how Medicare was one of the first payers for reimbursement for telehealth, and it was kind of a trickle-down effect. So Medicare would pay, and then the state Medicaid programs would pick it up, and then the commercial providers last would start to reimburse for those similar services. With telehealth, it's been interesting because some of the early adopters of telehealth were third-party vendors. So you would sign up for, and I'll pick on American Well, but there's, Teladoc, American Well, MD Health, there's a gazillion vendors out there. You would sign up for, to see someone via telehealth, but it was really of a list of available providers at the time that you tried to log in for whatever service that you were logging in. And generally you got just somebody that was in your area, but not necessarily your PCP or your specialist. And I've participated in stuff like that as well. And it's, for me, and maybe I'm showing my age, maybe a younger person would say that they don't really care who they see as a provider. But for me, that relationship between me and my provider is important. And I want to make sure that the continuum of care is available. I'm one of those that if I go to the Minute Clinic, I'm going to take the records from the Minute Clinic, or I'll go to a specific Minute Clinic within my own healthcare organization, so that it goes into my chart. My healthcare organization uses Epic, so that it's available to my other providers to say, oh yeah, you went over the weekend and saw a provider at the Minute Clinic, and what was that all about? So it's still part of my medical record. That's important to me, but I know sometimes if that's not the same across all generations. So we do have several people on the line today who have personally had telehealth visits, have helped grandparents, have helped set up things with the hospital staff. Great. That's good to hear. So I think we've got a good smattering of experience and intelligence with us today. All right. So at this time, I am really going to hand things over to Allie. Allie Orwig has been with the Indiana Rural Health Association for over 10 years and is very knowledgeable, runs our Indiana Telehealth Network program, which is one of the Federal Communication Commission's programs to reduce the cost of broadband access to healthcare entities. So Allie, I'm going to turn things over to you.
Thanks, Becky. I'm going to go ahead and share my screen here. Hopefully. It's thinking. Everybody can see those all right?
Yes, looks great.
Okay, wonderful. So Becky set me up pretty well and stole a little bit of my thunder because she talked about a little bit of the telehealth and telemed that I'm going to talk about, so it'll make it go that much faster for everybody. But I do appreciate everybody's time and Becky, your invite to have me today. We're going to talk about some broadband barriers and how to overcome those. I know we're not doing accreditation, but I do want to let everybody know I don't have anything to disclose. So there's that. So Becky really covered this pretty well on the healthcare side and even mentioned some of the other things like entertainment, listing off Netflix and Hulu and Disney Plus and Peacock, and it continues all the time. We have newer and newer streaming services. But here are some other things to consider when it comes to broadband in rural and just how integral that is to rural life now. Work from home, obviously, during pandemic, work from home and education both moved to the forefront because we couldn't go anyplace and our kids couldn't go to school. But as far as education is concerned, you should also consider advanced degrees and learning at a later age. It's not just your K through 12 education that can be done from home now. So many universities offer distance education and programs that are almost entirely online, if not entirely online. Another big one that is just growing all the time as well is agriculture, precision agriculture, utilizing drones, utilizing satellite GPS, self-steering tractors and combines, targeted application of seeds, water, and chemical. It's really just booming. In fact, I live just south of Terre Haute, and we have an Ivy Tech campus in Terre Haute that has added a whole new building on campus to teach precision agriculture and the repair of precision agriculture equipment. So it's only going to get more integral to rural life to have the adequate speeds to support all of these things. And then of course, shopping. We've all been on Amazon for a long time, but this ties into work from home as well. You have to consider folks that cannot travel, that have physical limitations that would prevent them from shopping or working outside the home easily. This is a very, very big deal for folks in rural that may have to travel half an hour to 45 minutes each way to go shopping or to their job. So these are things to keep in mind when you think about how important it is to have adequate speeds in rural areas. And then I'm not going to do too deep of a dive on healthcare. Like I said, Becky covered it very, very well. I just make a quick distinction between telehealth and telemedicine, whereas telehealth can be any of these things we've listed and some of the trackers Becky talked about, even tips just sent to your cell phone. Did you brush your teeth? You should brush your teeth with a fluoride-based toothpaste for 60 minutes. That can be considered telehealth. And then telemedicine would be the actual application of medical care, things like telestroke programs, STEMI gloves on ambulances, things like that. So what are the barriers to speeds that will support all of these things in rural life? Well, geography is an obvious one. This is location from the nearest connection. This can mean you might be miles and miles from the nearest fiber hookup, or it could be something as simple as I live down in a valley and the mountain or hill blocks my wireless connection. The neighbor let their tree grow too large, and now my home connection can't hit the satellite I was using. It can be as complex as getting all of the necessary paperwork and documentation to cross a bridge with a fiber connection or a railroad. Those can be major, major barriers in the construction of fiber and high-speed internet in rural areas. So another barrier is that you have access, but you just don't have enough. Maybe you don't have enough speed to pull off all of the things you need to at your clinic. Maybe you need to increase that, or maybe your reliability is not where it should be and you just cannot afford to get a redundant connection or build a fiber ring or anything like that. And both of these things really tie into the number one barrier, which is cost. You can overcome some geographic and speed/reliability issues if you can afford to do those redundant connections or pay for the higher speeds. But when it comes to construction and getting out to those last mile areas, it's still around $25,000 to $40,000 per mile to construct fiber. And there's some really neat pilots and programs that are out there right now that are working to combat this, working with local REMCs to put fiber on telephone poles. I've heard of some places where the geography is a little bit flatter. They're floating blimps with wireless connections in certain areas that can reach many more houses. So some really neat ways they're trying to get around this cost, but it's still prohibitively high in most rural areas. So how can we combat that cost issue? Well, the FCC has several programs that they have run for many, many years, and some that are rather new, that are to help rural healthcare providers and others get those significant speed increases without a significant cost increase. So the first is the telecom program, which is for both telecom and voice services, which is a little bit different than the other programs. It does also support voice services. The reimbursement rate for the telecom program is based on the rural-urban differential, so the price differential between the local urban area and the local rural. There is a database that they're working on at the FCC. They had started to use it, and then with COVID, they kind of stuck a pin in it. There might have been a couple little glitches in it they wanted to get fixed. So hopefully that will be out soon. It'll make things easy, but you can still figure that rate locally as well. Then there's the Lifeline program. This one, and I should have said the telecom program is for healthcare providers specifically. The Lifeline program, on the other hand, is for individuals, just, like you and me at home. This provides $9.25 a month, or up to $34.25 for tribal lands, for wired or wireless communication devices. So your cell phone or your landline in your house. And I want to also mention what Becky and I have been affectionately calling the Emergency Broadband Program, or Lifeline on steroids, which is now $50 a month or $75 a month for tribal lands, still for that wired or wireless communication. And it also provides a one-time $100 bonus, I guess you could say, to purchase a device. So if you don't have a cell phone, or you don't have a laptop or a tablet computer, they're doing a one-time $100 credit for that as well. And we all know $100 isn't going to fully buy a device, because they still want people to have skin in the game, and they don't want people to use that to purchase a device and then sell the device. So they have built some safeguards in there. But the way you are eligible for the EBB or the Lifeline program is to be at or below 135% of the poverty line, or alternately be on a similar program like SNAP or Medicaid, free and reduced lunch, things like that. I will say, built into the EBB program is a kind of like a rider for anyone that has a lost income due to COVID in the last year. And the income requirements for that are much higher than the Lifeline program. So even if you think you didn't apply, or some of your patients or constituents might not be able to apply, I suggest you look into that, because the income levels you're allowed to have, you just have to show a loss. They're fairly high. So E-rate is another program that is very similar to telecom, and then the Healthcare Connect Fund I'm going to talk about later, but it's specifically for schools and libraries. And that reimbursement that you get for that is based on the number of children living in poverty. The easy way to figure that is the number of free and reduced lunches, the percentage that is given out at the school that is seeking the funding. And it can be anywhere from 20% all the way up to 90% of reimbursement for your telecom services. So it could be pretty substantial if you're in a lower income area. And just a note on that is that recently the FCC announced that there is going to be a $7.1 billion with a B increase to the E-rate program. We don't have a ton of information on that yet, but it's a real commitment to increasing the speeds at schools and libraries. And likely there will be some inclusion of some sort to get to that end user, the kiddos at home that need the better connection. But that's a very substantial increase in the amount of funding available for the E-rate program. Then the next is the Connected Care Pilot Program. That just was released late fall, early winter. And unfortunately, it is a pilot program. So if you didn't already apply, it's not open right now, but it's going to be $100 million over 3 years. One of the neat things about this is it's actually to connect to the patient population. It's not just a connection for the healthcare provider itself. Typically, most of these programs are for the providers or for the hub, so the school or the library or the hospital or clinic, and not necessarily the patients. But this Connected Care Pilot Program is to reach out to those patients from the healthcare providers. It's up to 85% off the associated fees. It does not cover end user devices or medical equipment. And the first round of funded individuals was announced on January 15th. And since this is the Ohio group, you did have some CMHCs in Cincinnati that were funded as part of OCHIN, OHCHIN. So if you are one of those CMHCs, congratulations. Nobody in Indiana, Michigan, or Illinois got any of the Connected Care Pilot Program funding, but Ohio did receive some. So that's very exciting. If it's successful, we're hopeful that another round of pilot program funding or even potentially a long-term program could be instituted. The other thing that I want to talk about briefly, because it's another program that's not open for funding now, is the COVID-19 funding. There have been 2 rounds, one for $200 million and one for $250 million. The $250 million just went out here recently. And they have guaranteed that at least some money will go to each state. So theoretically, every state, if it was split evenly, would get at least $2 million of this funding. The window was from April 29th to May 6th. So if you didn't apply already, I'm sorry, it's too late this time. They have not telegraphed that there will be a 3rd round, but we'll see how long the public health emergency is extended. We'll see how things are looking later this year, if there could potentially be another round for that. But right now, there's no mention whatsoever. And then the final one is the Healthcare Connect Fund. We'll do a deep dive in this a bit later because this is the one that I work in the most often, but it is for telecom services for nonprofit healthcare providers, and it is up to a 65% reimbursement right now for those services. Before we get into the Healthcare Connect Fund, there are a couple additional programs outside the FCC. The USDA has a fantastic program, the Reconnect program, which is for rural areas. It's got 3 different options. There are grants, loans, and then grant loan combos. The caveat there is obviously it has to be in a rural area, and the minimum speeds that they will fund are 25 down and 3 up. So that's just their definition for what the program must be. With the grants, you can get $25 million, up to $25 million with a 25% match required. With the loans, you can get up to $50 million, and that is at 2% interest on those loans. And then the combo program allows you to do up to a $25 million grant in conjunction with a $25 million loan. And again, that's up to, you don't have to request the full amount, but those are some different programs. And then I know that this does not apply to Ohio, but I include it on my other presentations because I always want to encourage you to work with your Office of Community and Rural Affairs, is what they call it in Indiana. I'm sure there's a similar one in Ohio, and I know Becky and Dina have mentioned different groups in different states before. But often your lieutenant governor's office or your broadband office or your infrastructure office, or again in Indiana, our Office of Community and Rural Affairs, have funding for broadband into rural areas. In Indiana, it's called the Next Level Connections Program, and there are targeted census blocks around the state that they will fund some construction and different things. So I strongly suggest you reach out to your state government and see what offices and programs might be available to you. So Healthcare Connect Fund came out of the Rural Healthcare Pilot Program. It started back in 2009. It was only for rural entities. You had to be nonprofit. The entities that were allowed were hospitals, rural health clinics, community mental health centers, federally qualified health centers, and then community health centers. And you got up to 85% off of construction, installation, and then monthly recurring charges associated with getting high-speed broadband out into these rural healthcare providers. It was a pilot program. We were one of the, and I say we, the Indiana Telehealth Network, or ITN, was one of the funded pilot programs. You had to be funded during this to even be able to apply. We were one of 62 in the nation that were funded, and we were initially given $16 million to work with 72 participants in Indiana. Well, the pilot program was very successful. So 4 years later, in 2013, they announced the Healthcare Connect Fund, which now allowed anybody that was still rural and nonprofit to apply for funding. Now, one of the big changes was that you could also include non-rural sites as long as you participated as part of a consortium. And that consortium had to have at least 51% rural sites. So it did open the door for like smaller systems or groups of community mental health centers that might have an admin office or something, or maybe a couple sites are rural and a couple sites are semi-rural, but they don't fall under the rural designation. Maybe somewhere like a Kokomo or Richmond or Terre Haute. If you're not actually located in a rural area, but you're very close, you kind of hover on that line, then you could also apply as part of a consortium. They may change that rural designation. It may become higher than 51%. They have mentioned that in the past, but there's nothing concrete yet about that. So still, you can take rural and non-rural as long as you are part of a consortium. You still, as I said, had to be nonprofit. It was all the same designations, but also skilled nursing facilities are now eligible for funding. It did drop from an 85% reimbursement to a 65% reimbursement. And also it is prorated down from the 65% if we exceed the funding cap. So if there are more requests than there is funding, instead of just kicking people out, they start to prorate everybody down. And for this funding year that will start July 1, it is moving to tiered funding levels 1 through 8. And everybody will be funded starting at level 1. If again, this is just an if the funding cap is exceeded, they will first prorate or knock out level 8, then level 7, then level 6, and so on. But priority funding will be given to levels 1 first, moving up to 8. And the levels are based on how rural your site is and whether it is a medically underserved area. So level 1 is an extremely rural designated medically underserved area, all the way up to level 8, which is an urban non-medically underserved area. So it goes extremely rural, medically underserved, extremely rural, not medically underserved. Then level 3 would be somewhat rural, medically underserved. Level 4 is somewhat rural, not medically underserved, and so on. And then ITN, again, we started as that pilot program with 72 members. We've now worked with over 300 HCPs. I probably even have more than that after this funding year we've gone through. I should probably update that. But we've worked with over 300 healthcare providers in the state of Indiana and have done some consulting in other states as well to help people get this funding. So we're moving along nice here. So I'm going to do sort of a deep dive into what the Healthcare Connect Fund process is like, literally a how-to seek funding from the FCC. So the first form you have to file is called the Form 460. This determines both your site's eligibility as rural and then your eligibility depending on site type. So again, RHC, FQHC, CMHC, etc. And this includes the address, a contact at the site, your NPI number, your tax ID number, quite a bit of information just to determine that your site itself is eligible. And you do have to file one of these for every physical site that you want to get covered. So if you're a hospital with 3 clinics, that's 1 for the hospital and 1 for each clinic. So then you have 4 460s. And this is how you determine that consortium percentage of rural. So if your hospital and 2 of your clinics are rural, but 1 of your clinics is in an urban or semi-urban area, then you would have a 75% rural designation. Now, once you have your 460s all filed and your eligibility has been determined that you can participate in the program, then you would file a Form 461. Form 461 is the process of putting out all of your sites, usually with a request for proposal document, to take bids. Taking bids is part of the requirement of the Healthcare Connect Fund. You can't just go in and say, well, you know, I work with my local group and they're fantastic. They provide great service. I just want to stick with them. They're my incumbent. Unfortunately, not allowed. You do have to take bids from any interested party. All of the rules for that are laid out very clearly. I have included the website there at the bottom for USAC. USAC is the Universal Service Administrative Corporation. They're the administrative arm for this and most of the other programs, the administrative arm of the FCC. There's a lot more information here, so I suggest you go to this website and look into it more thoroughly. But the request for proposal will list all the sites that you have that want to take bids. You must then select, you score the bids, go through that process, but you must select the most cost-effective vendor. That doesn't always mean the lowest cost or cheapest vendor, but you must select the most cost effective and be able to make your case for why that vendor you have chosen is the most cost effective. So then once you've gone through the full Form 461, it's been approved, posted, you've taken your bids, you've scored them, you've chosen your vendor, then you file the Form 462. The Form 462 is where you submit each service that you're seeking funding for, line item by line item. So for example, if Hospital X is getting a 50 meg Ethernet connection with 2 ports, that's one line item for your Ethernet connection, one line item for port 1, one line item for port 2. If you had an install charge, one line item for your install charge, one line item for any construction you had done, and then you move on to Clinic X. And same thing, every service has to go into a pretty massive Excel spreadsheet that they have for you, the network cost worksheet, and then you get each service line for every site approved on the 462. That includes the cost and everything there. So finally, assuming you get a funding commitment letter, that is the approval of your 462, you are able to file for reimbursement of all the services that have been approved. This is essentially collecting all of your invoices for the time period, showing your proof of payment, so either a canceled check or sending in copies of your bank statements, showing that you have paid your percentage of the bill, so usually 35%, but if there's any prorating, it might be higher than that. You submit that through the USAC website, and eventually you get reimbursed for the services and the time period for which those have been provided. So after you go through all of that process, then you have your record keeping. You must keep all documentation associated with everything from that first Form 460 all the way through the Form 463 for 5 years from the last date. So the last time you apply for that reimbursement, there's your five-year clock has started. You have to keep every documentation every piece of documentation that you have. And that includes during your 461, there's often a lot of back and forth emails with the vendors and customers and just getting everything straightened out. All of that has to be kept as well, because USAC has started doing every year multiple audits. It's not an if, it's a when, and they are very, very thorough with their audits. So I suggest that you be meticulous in your record keeping. And again, you must keep those for 5 years. So again, here is the website with more information at the bottom about the Healthcare Connect Fund. And we've got about 7 minutes, really probably went a little too fast there, considering how much we had to cover. But if anybody has any questions, please ask them now. Use the Q&A function or the chat, or you can reach me at this contact information. And then I've included the website for the Indiana Telehealth Network, which is the consortium that I manage, housed at the IRHA. And I should be specific with this group that we are not required to stay within the bounds of Indiana. We can help anybody apply for this funding. So if you are interested, please do reach out. So Becky, any questions come in, or anything that I went over that I know you've heard this presentation once or twice?
No, thank you so much. And I'm sorry for stealing your thunder. There was, back when it was the pilot program prior to HCF, there was a group in Ohio that had some of those pilot funds. I almost want to say that it was the Ohio Telehealth Initiative, but I'm not sure. So if anybody on our call is aware of a group in Ohio that is participating in the Healthcare Connect Fund, please put that in the chat, in the Q&A. We'd certainly like to connect with them, but I am not aware of any organization at this time. Also, we talk a lot about our the IHRA organization, the Indiana, it's under the Indiana, oh shoot, not the governor, but the, what's her name?
Lieutenant Governor.
Thank you. Lieutenant Governor, and IHRA's, the Office of Community and Rural Affairs, has done a great job here in the state of Indiana. I am also not aware of the name of a similar organization in Ohio, would certainly be willing to share that information with anyone if anyone wants to put that information in the chat to bring that up. I should have asked Shane when he was on earlier, and I forgot to do so.
Yeah, and if there's not an organization in your state government that's looking at broadband and looking at rural areas and how they can support them, maybe you need to raise the alarm, because it's definitely something that's important. And I'm sure the State Office of Rural Health in Ohio has something available for you.
Yeah, I'm sure that they do, and I know that there has been funding dedicated in the state of Ohio to specifically work on broadband issues. So, is anybody aware of any organization like that? Go ahead and put that in the chat if you are. All right. Well, Allie, since you've got the next topic, do you want to go ahead and forge forward? You're muted.
I just said, yeah, I can do that. Okay. Definitely. So the other major function that I fulfill at the Indiana Rural Health Association is to perform community health needs assessments for our members. So today we're going to talk just a little bit about the guidance from the IRS and some things to consider. And I will try to, as we go along here, that this is my first time giving this presentation, assuming I go nice and quick, I will also give you a little bit of the idea of how we perform community health needs assessments at a great discount compared to some of the organizations that are dedicated to doing community health needs assessments, or universities that perform these for your rural hospitals. If I can get my slides to advance. Okay. So 501(r)(3) for 501(c)(3)s. This is the section in the IRS code is 501(r)(3), where they have all of the requirements for charitable nonprofit hospitals or 501(c)(3) hospitals. It was added as a requirement of the ACA in 2010. And it has to be completed on a facility by facility basis. And I have included the link here at the bottom that has the code and all of the requirements in it. I'm going to try to stick very closely to the language that the IRS uses, because I don't want to give you a bad interpretation. But we have actually at the IRHA been performing these for our members since, I believe, 2011. So we've got a lot of experience. And hopefully all the information I give you today is relevant to your facility and helpful to your facilities. But again, here's the website with the language for the 501(r)(3), and it really walks you through it very nicely. So when do you need to complete these? If you are a nonprofit hospital, it is every 3 years that you have to complete this needs assessment. I will say, if you own multiple facilities, you do have to do separate, we call them Chinas, CHNA, separate Chinas, unless you meet some of the other requirements that we'll talk about later for joint Chinas that can be completed, joint needs assessments that can be completed. And then I will also mention that the PHAB accreditation, the Public Health Accreditation Board, requires that any public health offices like state, local, or tribal public health offices that want accreditation also need to complete community health needs assessments every 5 years. Now, accreditation through PHAB is voluntary, but many local health departments and again, other offices in the areas that I mentioned do get that PHAB accreditation and require a 5-year China every 5 years. It's based on your taxable year. It's not based on your fiscal year. Or calendar, it's taxable years when we talk about, every so many years. And then with every needs assessment that you do, you also have to have an implementation strategy. You have to do one for every health needs assessment that's completed, and it has to be accepted by your board or governing body or your administration by May 15th of the following taxable year. So your whole report has to be done every 3 years and turned in by the last day of that taxable year. But the actual strategy itself has to be accepted by May 15th of the following year. You have to make these reports publicly available. What does that mean? Well, the easiest thing to do is to post it online on your website where people can find it very easily without doing a lot of hunting. But you also have to have physical copies available upon request, and they also have to be available without a fee. So if somebody comes in and asks for a copy and you have to run down to Staples and print it out and bind it and everything, you cannot charge that fee to the public person that requests it. It has to be a physical copy available for free upon request. And then you also need to have your prior 2 reports available. So the 3-year prior and then the 6-year prior need to be available. I suggest having them, again, both online and physically available at your facility. When you do that 4th China, you can get rid of that first one. It just has to be the 2 prior reports in addition to your current report. So conducting a China. These are the things you have to do during the process. You have to define the community that you serve. Kind of a no-brainer, but it has to be clearly defined. You have to assess the health needs of that community. Again, sort of a no-brainer when you talk about a community health needs assessment. Your whole point is to assess those needs. Solicit input from your community, and that the 2 very clear inputs that you need to get, there are many that you want to seek, but the 2 that must be included are people with specific public health knowledge, and then also representatives for minority or underserved populations. So cast a wide net, but make sure those 2 individuals or individuals representing those populations are invited. And then you have to document all of the work that you've done in a written report, and it has to be accepted by your authorized body. So how do you define your community? They've got some pretty clear guidelines about how you do that. You need to define it geographically, what your primary service area is. Most of our Chinas include primary service area only. We may address the secondary service area, but our specific report is focused on the primary service area. You have to define your target populations within that area, any principal functions that you might have, or specialties or targeted diseases in your area. It cannot exclude medically underserved populations. So it's not something that I think most facilities would do intentionally, but you need to be very intentional about making sure you are including your medically underserved populations. Also cannot exclude patients based on their method of payment or whether they receive any kind of hospital assistance or charity assistance. You really need to make sure all of these low income, medically underserved, minority populations are at the table and clearly defined in your report. So assessing needs, you have to assess the significant needs, and significant is maybe not the most black and white word. Well, that's almost intentional because you are allowed to use any criteria and any evaluation method that you want to identify what needs are significant. You can use whatever criteria to prioritize those needs. But I want you to keep your definition of health needs kind of broad because it can be financial or other barriers like transportation to care. That could be a health need. It could be focused on illness prevention, nutrition, socioeconomic factors. Really, the needs should be pretty broad, but then you can use whatever criteria to evaluate and prioritize those needs. And then you also need to consider resources that may already be available in your community to address those needs. And that may, again, be specific healthcare providers, but it may be other organizations in the community that are not providing healthcare, but are providing transportation, are providing cooking classes, things like that. All things you want to keep in mind. So then community input, I told you about the first 2 bullet points here. Definitely need to have a public health department or public health official or a member of your state office of rural health present or providing input into your report. And then secondly, your members of the medically underserved, low income or minority populations. If you don't have members that you can reach out to of these populations, organizations that serve or represent those populations are also perfectly acceptable. And then you want to take any written comments that you've gotten on your previous Chinas, and whenever they happen to come in, strongly suggest you file those and keep those in your records, because those should also be included in your next community health needs assessment report. So additional input outside of those 2 that you absolutely have to have, these are some suggested or ideas of people you might want to invite to participate on your needs assessment. We've had all of these different individuals come to our focus groups before. I would also suggest that you consider some student representatives from your school, some youth representatives. We try to make sure they're over 18. We don't want to get into any weird issues there, taking input from small children or very young people, but we definitely have included student government, student representatives that are 18 or older before. So that was how you go about conducting your community health needs assessment. This is what actually has to be documented in your report. Your community served, and we kind of talked about how you are going to define that. All of the processes and methods you used to conduct your report, and that's your data, your method, and then all of the collaborators or third parties that you may have used to conduct the China. So if you hire somebody like me at the IRHA to conduct your community health needs assessment, that needs to be identified and documented. And then you don't have to do all primary research on your own. You can definitely use outside sources. You just have to cite what those sources you used were. So, a lot of times I'll use information from the CDC or the Robert Wood Johnson roadmaps and rankings. We just have to cite those. Also have to document all of the solicitation and use of input. So who you invited to participate, how you used their input, what the input was used for. You need to talk about the time period that input was collected, the names of the organizations that participated. You don't have to put the individuals' names who represented those organizations. Often just listing the organization or business or whatever that was represented by that person is enough. You have to describe any medically underserved, low income or minority populations or the organizations representing them that contributed to the process, and all of the input that they gave, and kind of like a summary of all the input you received as well. You need to document resources available, and that's what I talked about earlier when it was, maybe it's the doctors you have available to treat certain things. It may be a local nonprofit that provides transportation or those cooking classes I mentioned. Literally any health or health adjacent resources that are available in your community to tackle whatever needs are identified. And then you need to have an evaluation of the impact from the last community health needs assessment. Often you can just show that by showing how the needle has moved on your community survey if you decide to do a community survey. But you definitely want to address how the last one has impacted your community. So collaboration and joint community health needs assessments, they are allowed. You can collaborate with other facilities as long as they have the same service area, the same described service area and population. If they have overlapping service areas, you can do this as well, but you have to very specifically and very clearly address, this is the area where we overlap, where our service area. Now this is hospital A's specific service area and how it differs. This is hospital B's very specific service area and how it's different. And you just have to be very, very clear on that. We have done some joint community health needs assessments with hospitals and health departments before. Like I talked about that PHAB accreditation for health departments. They do have to do them every 5 years. So on those very magic years, when the 3-year and the 5-year lines up, you can collaborate with other types of organizations as well. And you can collaborate on your implementation strategies, but again, it has to be very clearly and very specifically defined where and if and where those differences may be. So I have mentioned the implementation strategy a couple times. I want to talk just a little bit more about this because there are two possible responses when you have those identified significant health needs. The first is that you will address said need. You have to list out what you plan to do, what you think the impact will be, what resources are being committed, and that can be financial resources, that can be man hours, whatever it happens to be, you need to address that. And then if there's going to be any collaboration with other organizations or facilities outside of the hospital or organization that's completing the community health needs assessment, it needs to be very clearly defined what that plan will look like. Now, there may be a significant health need that has been identified within your needs assessment that you absolutely, you cannot address it. You don't feel that your facility can address it. Well, that needs to be included in your implementation strategy as well. You have to say why you feel that you can't address it. And that can be things like you just don't have the resources to address said need. Maybe other communities or other community organizations in your county or service area are already addressing that need. I'm trying to think, transportation is one that comes up time and time again when we do these community health needs assessments in rural areas. And the more rural the area, the more often it comes up. Well, maybe your facility doesn't have the ability to address this, but there may be a ride share or something similar in your community, discounted Ubers or Lyfts that are willing to take people to medical appointments. So if it's already being addressed by another organization, you just need to clearly document that and say why you are not, because someone else already is, even though the need may still be great. Maybe it's an identified need where you lack expertise to address it specifically, or there may not even be effective interventions out there that have been proven to, combat whatever the need is. If something very significant socioeconomically comes up, well, there are lots of interventions out there, but maybe not an effective proven intervention with peer-reviewed science behind it to address whatever area it might be. So just really the takeaway from your implementation strategy is you have to address it whether you're going to act on it or not. Then there are some special circumstances. Facilities that have been recently acquired or merged, a new hospital, and that can either be a new organization being developed and getting your 501c3 status, or it can be a physically new hospital facility built someplace. For both of these, the requirements are very similar. Your timeline changes just a little bit. They still have to be completed every 3 years, but you don't necessarily have to start one, boom, right off the bat. It is the last, a community health needs assessment is required to be turned in by the last day of the second year that the facility is either acquired, the date of the merger, or in the instance of a new hospital, the day that it is approved as a nonprofit, or the day that it is licensed, etc. Again, if you're falling into one of these categories, I strongly suggest you go back to that IRS website and look specifically just to make sure that you're following the appropriate steps for whatever your specific situation is. And then transferred or terminated hospitals, probably not surprising to anybody, you don't have to do a community health needs assessment if you have a closed facility. So the requirements then are waived under those situations. So really, that was my entire presentation about the guidelines, and I'm certainly open to any questions you might have now, but I'm also willing to talk just a little bit about the process that we use in our small rural areas. So I'll go ahead and open it up right now to any questions that we might have.
Yeah, I'm not seeing any questions, Allie, but I know I've always been outside the process of the Chinas when we've done them. So I'd like to talk a little bit more about that process. I don't know, we've done 10 to 20 of them. I don't know.
Yeah, I think we have completed roughly 15, I'm gonna say, and we have 2 that we're working on currently, and then we have already got 2 signed up for next year, a 3rd that we're talking to. So they're pretty good sized undertaking. If you have someone with the expertise and the excess time in your facility, that is obviously the most cost-effective way to go about completing these, because they are a requirement. I believe the penalty for not completing one or completing one without all the information that's required is a minimum of $50,000. So it's pretty substantial for not completing these. There are lots of places that offer to do community health needs assessments for you. We're one of them. Again, we do them for our members at an extremely discounted rate. Lots of universities and higher ed organizations can complete them for you. So there's some options, but yeah, we've been doing them since the requirement started.
Mm-hmm. And when you do one, let's specifically talk about critical access hospitals, because most of ours have been for critical access hospitals. So who is the person or the best contact at the hospital that you generally work with?
It's somebody different at every hospital.
Oh.
Sometimes literally the CEO is the point person for me because they know who to connect me to. There are some financial reports that we request, and like we always request your top diagnoses report for the prior calendar year, and we ask for your payer mix report for those top diagnoses, kind of helps show what populations you're serving. If you have low income populations, you can kind of infer that from the uninsured, underinsured, or then the Medicaid, Medicare. So it's different people around the hospital. Sometimes it will be your community outreach director or your community relations person, because there is a fair amount of work in the community and reaching out to community members. Those are some of the 2 most often that I see. The CEOs at critical access hospitals in Indiana have always been very involved in this process.
Very cool. Now, so I know you've done a couple over the last year during COVID, and those had to be all virtual. But since things are starting to open up, let's kind of focus on what it looks like when you do one and you're actually able to travel to the community. Where do you and I'm sorry, I got distracted during your presentation. Where do you generally go and gather people, or as people walk by you to take survey information?
Yeah, so I'll just kind of do a quick overview of what our process looks like. And this is an extreme simplification of what we do, but it'll give you sort of an idea of how we go about it in a critical access rural community. So we'll start off by having at least 2, sometimes 3 focus groups. When we can do them in person, we can do just 1, but 2 allows people to attend that maybe had time constraints one day or another. We solicit the input of all community members that want to attend, but again, we try to make sure that a public health officer, department, or state office of rural health person is in attendance. And then of course, those individuals that represent, or organizations that represent, medically underserved, low income, and minority populations are present, because we want to take their input into account. We go through these focus groups. We've got a process where we have everybody identify the needs in the community, and then we prioritize them there at that meeting. And we put that into a survey, a community survey that we put out in whatever the defined target service area is, and collect results that way. That is our primary data. We also do secondary data, where we go again to those resources that I mentioned earlier that are already in existence, like Robert Wood Johnson Foundation, CDC, National Cancer Institute. The Annie E. Casey Foundation has a lot of good information on the youth populations. Any kind of data sources like that exist. Sometimes it's actually the Department of Health in the state, like the IDOH in Indiana. We pull a lot of data from them. Any place we can get that data that would be very hard for us to collect, we try to include that. So then we've got the kind of 1-2 punch of your community responses about the health needs. We pair that with all the previously existing data, that might show cancer clusters or high prevalence of diabetes or things like that we might not be able to collect ourselves. We put those together. To your question, Becky, about how we do those surveys, we like the hospitals to put them on their website, push them out through social media and stuff like that. But we also understand there are populations that the internet access could be a problem. So we will try to go to, first of all, we try to have paper copies whenever we can in the hospital waiting rooms or clinic waiting rooms. But then we'll also work sometimes with the health departments, with local libraries, places like that don't mind to put the surveys out and just hold on to them for us until we can come collect them. So that's how we connect to the population that does not have internet access. And then we also try to do, when COVID's not happening, go into the communities and then do face-to-face polling at different places. We've done them at supermarkets, libraries, YMCAs, farmers markets, any place people are and we're allowed to go. The hospital will work with us to find good spots around town with high traffic. We try to catch those people again that may not have seen the survey online, and just people going about their daily business. We try to keep the surveys as compact as possible. They typically take somewhere between 3 to 7 minutes to complete, depending on how many needs have been identified by those focus groups. So we take all of that data back, we compile it into a report along with all the other documentation pieces that are required by the IRS that we went over today, and we put together the needs assessment portion of the report. We often have a section we call opportunities, where we might give you some ideas about programs in other areas that address some of the prioritized needs. And we do list what those those high level, usually somewhere between 7 and 10 most significant needs in the community are. And then we try to offer some helpful hints and suggestions about things you might want to include in your implementation strategy. But the implementation strategy is actually completed by the hospital or healthcare facility themselves. We don't want to come in and say, this is what you will do. It should really be completed by that facility themselves in collaboration with any other relevant organizations in town. So that is the way back 50,000 foot view of how we go about them. They're very doable if you have a little bit of experience and you follow the guidelines, but that's our general process, leaving out quite a lot of the specifics.
Yeah, thank you. That's very helpful. And you mentioned libraries, and fun fact that I learned this week, and shameless promotion of a previous webinar we did this week with MKM Design, which should be up on our archived webinar page. There are more libraries in the United States than there are McDonald's. And we got into an interesting discussion about using libraries as virtual care locations for patients, and how libraries function as, and librarians as individuals kind of function as a open ear to people that use libraries, and kind of a health counselor, a psychiatrist, those types of things. It was a very interesting discussion.
Oh yeah, definitely. The local libraries have always been one of our best resources when working outside the healthcare provider themselves. They're always willing for us to be able to come and do surveys. Many of them are willing to put the surveys out and then collect them for us, as I said. But yeah, it's, Becky, that I'm married to a librarian, so I have a good perspective on the library system in rural areas. But the things that people go to the libraries for in rural communities, and I'm sure other communities as well, are broad. Help with taxes, help with getting insurance. You want to rent movies. I mean, it's literally the gamut of things you can imagine that people go into libraries for. So
Yeah. Well, and I also happen to know specifically that your husband's library did allow open broadband access for kiddos when they were kind of kicked out of the schools last spring and able to come and do homework and stuff there.
yep, absolutely. And they had pucks, internet pucks that you could check out and take home as well for folks that didn't have reliable internet. And they still do. It's a service they offer. So yeah, libraries should always be considered when you talk about broadband or community anything in rural areas. Definitely, libraries are such a champion for pretty much any initiative you've got going. Don't forget about them. Don't sleep on libraries.
Well, thanks so much, Allie. I really appreciate your time today and your wealth of knowledge in this area, of both of broadband and for community health needs assessments. So thank you.
Definitely. So please, anybody that comes up with questions about either, reach out to me. If I don't have the answer, I will find you the answer, or I will direct you to the person who has the answer. So go ahead and write down my email, my phone number, and check out our website. So thank you, everybody.
All right. Thanks so much. All right. We're just a couple minutes early, but I'm going to go ahead, and I made the mistake of letting my dog inside. So cut this out of the recording, but I'm going to let my dog out, and then we'll come back in just a moment. If we could have 3 minutes of music, we'll come back and jump right into workflow. Thanks. Okay, so that didn't take long. Let's go back to our regularly scheduled program. I'm going to share my slides, and we're going to jump into workflow and incorporating telehealth into your organization. And I like to talk about this as a culture change. Many individuals or organizations were forced into doing telehealth last spring when COVID hit. Luke Wortley, who is also on our team, takes the majority of what we call our technical assistance calls that come in through our website, via email, through the National Consortium of Telehealth Resource Centers website. And we were just, it was a tsunami. We worked many long hours last spring to try and keep up with the requests for information as things change so rapidly. And so many organizations, when all of their patients were told to stay at home, were trying to scramble to put together some type of a way to see their patients virtually. So when you start thinking about incorporating telehealth into your organization, there's 3 basic steps. You need to assess, go assess and define your, what it is that you want to do. And the Chinas, and that's specifically why our program is ordered the way it is today, the Chinas that Allie talked about are one of the best tools in your toolbox to assess and define what's going on in your market area, what is the low-hanging fruit as far as telehealth and meeting the needs of your local community and population. So once you know what those needs are, then you can develop and plan to how you want to meet those needs. As Allie said, you don't want whoever is doing your China for you, your community health needs assessment, that's not the person that should be, or the entity that should be saying, hey, this is what you need to do. This is what you're going to do. It's back, the onus is back on the organization that has putting the China together, that critical access hospital or what other organization that might be. So once you start and think about it, figure out who is going to be on your team and develop and start planning towards a work plan. And we'll go through a sample work plan here in just a few minutes. All right, then the next step is to implement and monitor. So once you've gone live with whatever new program you want to institute, then you need to have a baseline of data to say, you know, this is where we are now. And then you have a place to come back later and say, well, this is what changed. And then sometimes you find things that are you didn't think about when you're implementing your plan, or you didn't take into consideration. And so you tweak your plan. So that's why you come back and you monitor, and be it every month or 90 days or 60 days, whatever it happens to be. And so you come take a step back, monitor your program, tweak it, and implement again. So that's what we're going to talk through in this particular segment. All right. Now, sometimes you might hear PDCA. And this stands for Plan, Do, Check, Act. So that is just another way of thinking about, or process for thinking about how to implement something new in your organization. So I like to use the as a frame of reference for this discussion, I like to use the book, Who Moved My Cheese? Now, I first read this back in the mid-1990s, so I'm dating myself. But this is the story of Hem, Haw, Sniff, and Scurry. And they represent in our workplace 4 different personalities. So Hem is a stabilizer and wants everybody, you know, to just kind of be calm, and likes a structured approach, a slower pace. Scurry is our producer. Scurry wants to get it done, get it done, and has a very short view, is thinking about, you know, the next meal or the next day and not 6 months from now. Haw is our unifier that tries to get everybody to be on the same team, but likes an unstructured approach and is real process orientated. So we're going to do this, and then we're going to do this, and we're going to do this. And then Sniff's our innovator. Sniff is what I call an individual that has like shiny-itis and the new technology, and always wants to own the newest version of whatever mobile phone or tablet or computer or whatever is out there. But Sniff is also very results oriented. We want to get to Z, so we're going to get there. We're not sure how we're going to get there, but we're going to get there. That's our goal. And Sniff is concerned with the long view. So what's going to happen in a year or 5 years or whatever. So I want you to think back in your workplace about these personality traits, and I bet you've already picked individuals in your workplace that exemplify these 4 characteristics. So both, I mean, it's a double-edged sword. The beauty of working with a lot of people is that you've got a lot of information, a lot of perspectives, but sometimes you have very different personalities, and whoever's going to lead that team has to be able to figure out the best way of dealing with and working with all of those different personalities so that the team can move forward in a positive direction. So assessing and defining your program. So you're going to do your needs assessment and define the environment for which you need to develop a new service or incorporate telehealth into your organization. The most important person is going to be your telehealth champion. And this is someone who has the vision for telehealth, for incorporating telehealth into your organization, and the communication skills to work with a variety of different people and personalities, and the time to get it done. It's so important that it not just be dumped on someone that doesn't really have their plate cleared of other responsibilities. It is a very time-consuming thing and a lot of piece parts that need to be put together in the right order, in the right structure to create a sustainable program. And we'll talk about financial sustainability later. All right, so is there a corporate willingness to invest in this program? And that could be time, and it could be resources. There probably is going to be a little bit of money involved as well. And then what healthcare services are not available? And that is something that you should find out in your CHINA. Now, if you're not familiar with CHINAs, and this was a new topic for you today, every entity that does a CHINA, the results should be publicly available on that organization's website. So take a look at that. And then you need to identify and prioritize telehealth appropriate services. Now, what we're going to use for our example today when we look at a work plan is going to be a telepsychiatry or behavioral health. That is one of the lowest of the hanging fruit because all it is a conversation. We don't have to worry about vital statistics. We don't have to worry about palpating an abdomen or looking in an ear or down a throat. It is literally just a conversation. So all that we need on the patient side and the provider side is some type of smart device. You could use a smartphone, a tablet, a computer, a laptop, and we need visual. So to make that audio visual for reimbursement, so we need some type of a webcam. And most of those devices today, monitors have built-in webcams, tablets and smartphones have built-in webcams. So it makes them very appropriate for this type of service. And then what are your assumptions and constraints? Are you assuming that the service will only be available 8 to 5, Monday through Friday? What if someone comes into the emergency room midnight on a Saturday night and needs a psychiatric consult? What are you going to do then? Do you have the available providers that can provide that service 24/7 in an acute needs situation? Or is it only going to be for normal office visits? Maybe you need to hire a third-party vendor or contractor to cover evenings and weekends. Those are the kind of things you need to talk about with your team at this point as you start to develop your plan. Now, I happen to have a black belt in lean healthcare management from Purdue University here in the state of Indiana, and that's just one organization. There are many organizations that do Six Sigma training and lean training and Kaizen training. There's all kinds of different ones out here. I have experience in both lean and Six Sigma, so I go back to these methodologies, these thought processes when I think about how do we get rid of waste. So there's different buzzwords for each. But in lean, we talk about overproduction or waiting or just in time or transportation or motion or over-processing inventory and defects. With Six Sigma, we're more concerned with the terms defining and measuring and analyzing and improving and controlling. Regardless of the terms we use, both of these thought processes are all about getting rid of waste. Now, several years ago, I attended a National Rural Health Association conference in downtown Louisville, Kentucky. And one of the coolest things that I saw were waste cans that were actually solar powered to compost that waste in the middle of the city streets. So I thought, what a great way to introduce efficiencies into a specific process. All right, so now we're really going to start developing our plan. We need to define and specify the program model. Like I said, are we going to do this 8 to 5 for psychiatry? I'll continue to use psychiatry or behavioral health for our examples today. So we need to know, where are the patients? Are they at home? Are they at the local clinic? Are they in the emergency room? And then where are the providers? So we know what services best meet those patients' needs. And then what technology do we need? So I talked about with behavioral health, we just need a device and a webcam so we can have a conversation. But if our need is for cardiology or neurology, then there's going to be more devices used, and the patient's probably not going to be able to be at home because there's different testing that needs to be done, or palpitation, or whatever it happens to be. And then, so what's the best organizational model to put together that patient and that provider so they can have that telehealth consultation or that virtual care visit? Human resources will be involved, not only the patient and the provider and whoever is running the program, your telehealth champion, but your human resources department within your organization, because there may be contracts that need to be signed with the provider. There's probably paperwork. We'll talk a little bit about HIPAA and consent and documentation as we go on today. And what about facility related resources? If you're going to be homing that patient or rooming that patient within your clinical walls, you need to have space to do that. And then who's going to provide that service? Again, who's the provider going to be? Is that a staff member that's already employed by your organization? Are you going to look to a third-party organization for a contract employee? What's that going to look like? And then legal and regulatory constraints. We don't really talk about, in today's list of topics, we're not really going to get into licensing or credentialing, any of those things, but those are all things that happen behind the scenes that have to be done in order for that provider to legally provide services at your organization. And then what is your implementation approach? Is it going to be a phased approach, a pilot approach, or open up the doors and anybody that walks in can be seen? We've, prior to COVID, we really recommended a phased or a pilot approach. Maybe you would start a program with Medicare patients because they often have mobility issues, so it's easier for them to be seen from home, or Medicaid patients that might have transportation issues, so it's easier for them to be seen at home. Regardless of how you start, you need to know what patient population you're going to look at, and being able to mine your electronic health information is going to make that easier, so you can determine if there's maybe you want to start with patients that are your frequent flyers in the emergency room at a critical access hospital or another hospital organization. Or maybe you want to look and see how many patients are new to Medicare, and you want to do your welcome to Medicare visits via video. Maybe you want to look at knowing that the top 3 diagnoses that are hardest hit in the United States. Maybe you want to look at diabetes or COPD or CHF. Maybe you take one of those populations and you see, well, your diabetic population. When was the last time, you've got 300 diabetics, I'm just picking easy round numbers, in your database of patients, 300 of the 300 total diabetic patients, and maybe only 100 have been seen within the last 6 months to get an A1C. Well, maybe you reach out to those others, find out why they haven't come in, schedule times with them. Maybe you want to have them come into the lab and get their blood work done and get their A1C. Or maybe you want to start continuing education programs for diabetes self-management or something like that. All right. One of the tools in your lean healthcare toolbox, and one that I like to use frequently, is called the 5 Whys. And it's really a way to get down to the nitty-gritty and identify what is the root cause. So this is a root cause analysis way to do that. And our example today is going to be that I ran through a red light. Well, why did I run through a red light? I was late for work and I was trying to hurry up in traffic. Well, why was I late for work? Well, I woke up late. Okay, well, why did I wake up late? Well, my alarm clock broke. Why was your alarm clock broken? Well, I didn't check it the night before. Why didn't you check it the night before? Well, I forgot to do it last night. So the reason I was late for work is because I didn't check my alarm clock last night to make sure that it was functioning to wake me up on time. And then I was running late and ran a red light. So the root cause analysis, we're not going to try and reconfigure the light, the timing of the light. What we're going to do is we're going to fix that alarm clock and make sure that it works properly so that everything else falls into place. So I hope that makes sense. All right. So part of changing the culture and incorporating telehealth into your organization, part of it is developing a business plan or a business case. So looking at, you again, going back to your China, looking at those community health needs assessment reports and looking at the information that came out of those focus groups that Ally talked about. So does the proposed telehealth program fit the mission of your organization and the need that you found in your needs assessment? So we've got to have that buy-in with the organizational mission. It's got to be within your scope of practice. And you're going to have to obtain that financial commitment to implement and sustain your program. You might have startup costs covered by a grant or other outside funding, but in order to really have it financially sustainable for the long term, you have to make sure that you can afford to hire the providers, to have the space to do it, all of those different things. You have to buy technology. And part of your business case is going to be looking at your payer mix. Do you have a lot of Medicaid patients or a lot of Medicare patients, or do you primarily commercial patients? And the revenues that you gain from those are what's going to sustain your program, along with the number of patients that you see via that telehealth platform. So that'll help you understand whether or not the project is truly sustainable. All right, and then program savings. So I talked about that just a tiny bit. But think about scheduling and physicians not having to travel, patients not having to travel. And again, those ancillary costs for those laboratory fees, be it blood draws, x-rays, MRIs, CAT scans, all of those things. If you can do those locally within your local economy, or if you can do those within your organization to have those extra revenue generating services. All right, so let's come back to hem, haw, sniff, and scurry. So we're going to do this new program. We're going to, again, for my example, I'm using telepsychiatry for this process today. So we're going to start a telepsychiatry program. We've got all of these different personalities working on the team. We've got to figure out, to get to our end goal, what outcomes we want, what objectives we have to meet, what are our deliverables, and assign certain deliverables to the right person, the right personality on our team. So we might have people from HR involved, we might have IT involved, definitely going to have medical staff, and we're definitely going to have the nursing staff or medical assistants that are going to be with the patient if the patient's going to be in a clinical setting. All of those things have to come together. All right, so as we plan our program, we need to know what our work plan objectives are. We need to identify for those team members, what are their specific roles and responsibilities, and who is going to be that telehealth champion, who's going to be our team lead to bring this all together. We need to develop a communication strategy or a marketing strategy. So if you've got a marketing department, get those people involved as well, because you can have the best program since sliced bread, but if nobody knows about it in your community, you're going to be dead in the water. So how are you going to market that? How are you going to let your community know that you have this new service? Are you going to put up billboards on the highway if you're close to a highway? Are you going to take out ads in a local newspaper? Are you going to do TV commercials on a local TV channel? Are you going to direct mail your patients or snail mail your patients? And what about social media? Does your organization have any social media accounts that you can push this across? In all honesty, it's probably going to be some combination of all of these things that I've listed. And there's probably things I haven't even thought about. Having a postcard available in your doctor's office, having the automatic message when you're waiting to talk to a live person, have that mention that you have a telehealth program. How do you go to find out more information about that? All of these things are possibilities. Now, whatever you decide to do, you need to make sure that you have policies and procedures, clinical reference guidelines, scheduling. Your schedulers have to be in on this. How do you know when a provider looks at their schedule, which of their visits are in person and which of their visits are virtual? You're going to have to figure that out. There's too many scheduling apps and programs out there for us to say, oh, do it this way. It's going to be different for every organization. And then process integration. And this means practice, 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 and training. And we're going to have an opportunity for practicing at the end of the day today. So other work plan objectives, if the patient's going to be in your clinical space, then where is that patient room going to be? Is there adequate broadband services in that room? Or if the patient's at home, do they have adequate broadband services at home? What services are available to them at home? Do they have broadband? Do they need assistance with broadband? Do they need a device? And going back to some of the things that Allie discussed, there are additional consumer programs out there like the Emergency Benefit or Broadband Benefit Program or EBB that you can let consumers know about those so that they can take advantage of those programs and be more able to have telehealth visits from home. And then support. So look at your own internet access within your own organization. Usually it's handled by your IT department. When you look at those contracts for service, if you get them from a telecommunications company or a cable provider or an internet service provider, it doesn't really matter, but you need to look at those contracts. What happens if you have an outage? Because you always want to have a plan A, which is your go-to plan, but then you need to have a B and a C plan and sometimes even a D plan. What happens if there's an internet outage, there are issues with sound or video, that telehealth appointment can't be completed as intended? Then what? What do you do? So those service level agreements with your broadband service providers within your organization are going to be key to getting your service back up. And you might also have maintenance agreements on any hardware and software that you're using as well. So you need to know those help desk numbers need to be made available. And on the patient side too, think about that, especially if the patient's not in your clinical environment. If they're at home and the connection gets cut, they need to have some information. So who do I call? How do I figure out what's going on? And, what is the patient's plan B, C, and D, so that they can reconnect with either their provider or at least the office where the provider works for next steps, for rescheduling, for changing it to an audio only visit, those types of things. All right, and then interoperability and scalability. So here is your integration with your electronic medical record or your electronic health record. How does that interface? We're using Zoom today. So I'll pick on Zoom as one of many platforms that you can host telehealth appointments on. A couple others that I've been looking at recently include WebEx and Microsoft Teams. Some of the really popular platforms here in the Midwest are Doxy.me or Doximity or MS Teams or WebEx or Zoom. Yeah, I think those are all of the most frequent ones we hear. But if you have electronic medical records that have a video module built into them, if you're an Epic shop, you have MyChart that you could use video visits within MyChart. Cerner also has video modules built into it. Amwell, there's a couple other on the list that have video visits in them. So if you've purchased those modules, you can integrate your telehealth visit and that documentation right into your EMR instead of taking it in one place and then having to import it into your EMR at a later time, or double entry, which is time consuming. And then organizational approval. If you're purchasing equipment, who signs off on that purchase? If you need to procure any other contracts or additional internet access, anything like that. All right, now let's talk about outcomes. So what do you propose to meet in your program? You're going to have program goals or project goals. You're going to have objectives and then your outcomes that you think that you want. So we'll look at those when we look at our sample work plan. And then patient volumes and utilization. That's going to key into the revenue. If your patient is a Medicaid patient, a Medicare patient, or a private payer, you're going to be able to estimate what those revenues are per patient. And then you're going to track your utilization so that you can achieve the goals that you set out for yourself. Also, when you think about your outcomes and your tracking, you want to have a data collection methodology set up prior to starting the program. This means surveys, patient satisfaction surveys, provider satisfaction surveys. And then what happens, you can't think of all of the variables. There will be something that you haven't thought about that comes up, and you'll have to adjust your program for that and then move forward again. And so you have to kind of have in the back of your head, or maybe in a procedure if you want to document it, some type of a course correction process. And that may just be weekly team meetings or bi-weekly team meetings to make sure that everyone within the team is aware of what's going on. And then your program improvements, you have to define, plan, implement, test, and manage the process. All right, so here's our sample work plan. And again, I said I'm going to pick on telepsychiatry. So here I'm making an assumption for this particular scenario that we are a critical access hospital and we want to reduce wait times for psych consults in the emergency room. So this is our overarching goal. What do we want? To reduce ED wait times for psych consults. How are we going to get there? That's going to be our strategy or our objective. We're going to provide telepsych services in the emergency department. Well, under activities, what are the steps? How are we going to get to that end goal? We've got to go through A, B, C, D, E, the whole alphabet to get to Z. We can't just jump over from A to Z. So we have to find a space for that patient in the emergency room or local nearby. It is a private space. We have to invest in video conferencing technology, some type of a platform. And we don't have psychiatrists on staff, so we're going to have to hire a third-party vendor or find and hire a psychiatrist that's going to be 100% dedicated to our organization. So who's going to be responsible for what? Hem, haw, sniff, and scurry all need jobs. Who's going to do what? So we've got our team lead, and then we've got two team members, team member A and team member B. Now, how long, the team lead is going to find the space. Team member A is going to investigate and find out what it's going to cost and get the appropriate video technology installed. And team member B is going to work with HR and find a psychiatrist. All right. So our time period, what's our time frame for getting this done? How long will it take? So by fourth quarter of 2020, and I've given lots of time here, prior to COVID, it could take 6 months or a year to start a telehealth program. And I know probably many of you on this call today had to do it overnight. So blessings upon you that you've overcome those challenges. And there might be additional services now that you want to take a little bit longer approach, more detailed thought process to add different telehealth services to your program. So here, for this example, we're going to use fourth quarter of 2020. So what are our outcomes and process measures? How do we know if we've actually achieved our goal? So we're going to set a goal of seeing 60 patients via telemedicine or telehealth or virtual care by the end of fourth quarter 2021. Now, something that you need to keep in mind in the upper right-hand corner of the slides here is that we have used SMART goals and objectives for this particular work plan. Our goals are specific, measurable, achievable, relevant, and timely. So I put fourth quarter 2021 because you know what? I would much rather blow the outcomes out of the water and have, by the end of third quarter 2021, have seen those 60 patients than set a goal for, by the end of June, which is next month, to see those 60 patients and not meet the goal. So I like to overachieve on my goals. All right, so that implementation and monitoring phase, when you start, you really need to make sure your communications plan is in place, that your patients know this is a new service, that you've communicated within your organization as well, and everybody is on the same page and ready to go. And the more that you identify and mitigate risks, the better off your program is going to be. And for monitoring, you need to make sure that there's somebody, maybe an evaluator, a data coordinator involved to check in and see, each week how many patients are being seen, and each month. So the timing will depend on how often your team is going to get back together to look at what has happened. In the beginning, you might want to meet each week and review from the previous week, tweak, make changes, and then go forward. But after a few weeks or a month or two, maybe you want to meet on a monthly basis with your team and coordinate all of that information and move forward. It'll just depend on the pickup, the number of patients that you see virtually, and what kind of variables that you run into throughout the first few weeks of the program. All right, so always make sure to celebrate your wins. When you start something new, it doesn't matter if it's a written a printed certificate or a fancy little statue or a pizza party or a day off or a $5 gift card to the local coffee shop. You need to reward your team members for doing a great job. So celebrate your wins. And then always remember that plan, do, check, act. Once you've started acting, it doesn't mean you never go back to planning again. You always got to go back and monitor how far you've come so that you can celebrate the wins, but then tweak things as necessary for implementation. So it's not as easy as it sounds. There's a lot of details involved. And that's why it's so important to have a work plan and have those objectives and have regularly scheduled meetings with your team members. We're going to get more into the good, bad, and the ugly and some problem solving this afternoon, but we will talk about telemedicine room setups. One of the things I want to leave you with today is a quote from the book that I've been talking about, Who Moved My Cheese by Spencer Johnson. So change happens. They keep moving the cheese. Anticipate change. Get ready for the cheese to move. Monitor change. Smell the cheese. Make sure that you know if it's getting old. Adapt to change quickly. The quicker you let go of the old cheese, the sooner you can have the new cheese. Change. Move with the change. Enjoy change. Savor the adventure and enjoy the taste of the new cheese. But be ready to move again quickly because they keep moving the cheese. All right, so there's my contact information. I did go a tiny bit over on this particular presentation, but let's take a minute or two. Are there any questions or clarifications for talking about changing the culture of your organization and incorporating telehealth into your organization? All right. Hearing none, I'm going to go ahead and get my next slide deck up and running. So next we're going to jump into policy and reimbursement. I'm going to cover Medicare, and Nichole Small from the Ohio Department of Medicaid is going to cover Ohio Medicaid. So let me go ahead and share my screen again. All right. So I mentioned earlier that that Luke Wortley and I handle a lot of the technical assistance calls that come into the Upper Midwest Telehealth Resource Center. So we call them TA requests for technical assistance. And one of the things that we have to do for HRSA as our funder is provide reports to them. So this last time we were providing some reports, and we did a look back over the last 5 years to see how many TA events we had each year. And you can see here the increase year over year in technical assistance requests that we got. And the exponential increase in TA activity during the year of COVID. This is another way of looking at that report. This report looks from January 2020 to December of 2020. And you see this huge spike March and April of last year when the pandemic really hit the United States. And most states were on lockdown all over the country. But this gives you an idea of the increase that we saw in technical assistance requests as you look at the year in a whole. You also see here our outreach, and outreach is things like the training that we're doing today, or individual webinars or virtual office hours, those types of things. And you can see those there, number of participants and the number of events. There was a huge spike in April because as I talk about all of the changes that happened from a Medicare perspective last spring, all of the changes happened for the most part in March, and in April we were able to say, okay, this is what we know, and start doing some trainings. And also here you can see our website visits. So you see our website hits increased dramatically in the spring of last year, and even towards the end of the year they're still higher than they were pre-pandemic, and that has continued to follow in 2021 as well. Other things you can see here is the organization types and the number of people involved from different types of organizations that came to us with questions. And how did they come to us? Did they send us an email? Did they call us on the phone? And then how did we provide information back to them? 9 times out of 10, it's email. Even if they call us on the phone, we have a conversation, we're going to send out an email with links to resources or that type of thing. And then, so our 4 states, what was represented in the previous slides is our 4 states, Illinois, Indiana, Michigan, and Ohio. Now, we are part of the National Consortium of Telehealth Resource Centers, and this program has been around from a federal perspective since 2006. We also have other regional telehealth resource centers. There's 12 of us that cover all states in the country and DC. And so this data is national data from the 12 regional telehealth resource centers, as well as the 2 national telehealth resource centers, the Center for Connected Health Policy and the Telehealth and Technical Assistance Resource Center. So you can see here the telemedicine visits per week, and the highest were in the Northeast here. And again, you see that increase, that dramatic increase in March and April, and it started to taper off a little bit in June in the Northeast anyway, but then that is when Arizona, Florida, and Texas had the highest number of visits per week. And again, here a national look at the technical assistance, total technical assistance events like webinars and conferences and stuff, and then requests related to COVID and new contacts. All right, so I've been talking about last March and April all morning, but what happened last year was CMS added about 80 new codes to the list of telehealth reimbursable codes. They also took some audio-only codes and made those reimbursable because there were many individuals that didn't have adequate broadband access, that didn't have smart devices. And so all that they had available to them was their landline telephone. Medicare eliminated geographic barriers. So for the first time, Medicare beneficiaries could see their providers from home and the providers were able to be reimbursed from Medicare. The other big barrier that Medicare waived is the rurality. And we'll talk about that in just a moment, about how prior to COVID, a Medicare beneficiary had to be at a clinical institution that was an eligible entity. They had to be in a rural area, and there's a database where you would go to figure that out. So those two barriers were removed, allowing more Medicare beneficiaries to benefit from access to health care through telehealth. Also, Medicare expanded the roles for certain disciplines for occupational therapy, physical therapy, and speech language pathology. Those three disciplines were not able to provide services via telehealth prior to COVID, and now they can. There were also a lot of other waivers around supervision with fellows, with interns, students, the number of visits that could be had in a skilled nursing facility or in an inpatient setting. All of those rules changed as well. There's a link there to the physician fee schedule, the proposed physician fee schedule that came out in late July last year. It always comes out in July, and the proposed physician fee schedule is kind of a look forward to what Medicare thinks that they're going to do for the next calendar year. So many organizations look to that to see what's going to change for the next year. There's a comment period, and this happens every year. Our National Policy Center, CCHP, when these types of things happen, puts out a fact sheet, and that's available even today on their website. You can go and look at that if you want to look at the history of the last year and how we kind of got to where we are today. I mentioned we talk a little bit about HIPAA. So when COVID first hit and all of these changes hit, every CMS, as well as every state in the country, put waivers in that basically said, stay at home, but you can use any type of video conferencing technology to see your patients. So these are here, we had set up COVID-19 resource pages on our website. Those are still there if you want to look at them, and all the different executive orders from the states. Ohio said that any audio or video non-public facing remote communication product that is available to communicate with patients is allowable, but they should not use public facing. It should be non-public facing. So not Facebook Live, not Twitch, not TikTok, but Google Hangouts, which is a one-to-one connection, or Facebook Messenger video chat, FaceTime, Skype. All of those things are okay. And right now, there are not penalties for not using a HIPAA. There are not penalties for not using a HIPAA compliant video conferencing product or platform for the patients and the providers to meet. But we are now 14 years into this, so we strongly urge you, if you're still using a non-HIPAA compliant video conferencing platform, to really do your research, look into it. I've given you some examples of popular programs, and certainly happy to take questions. Certainly you can email me if there's additional questions about platforms. I might even send you to our National Technology Center for specific questions on different platforms or digital peripherals. All right, so all of that has happened during COVID. This is just an example of all of the myriad of changes that CMS made last spring, with links if you want to go out to the CMS website and read through the frequently asked questions or the policies or any of that. As I mentioned earlier, we did set up COVID-19 pages for each of our 4 states on our website, so you can go into your state page and go back and see all of the executive orders. And some of them we've got the gradual reopening plans from each different state. All right, so leading up to this, or kind of simultaneous to everything I've been talking about, is the federal public health emergency. Now, that was first instituted last March, and under the Trump administration, under the previous White House administration, every 90 days they would extend the federal public health emergency another 90 days. And if you look back at some of the links that I've shared here where you can find that information, I think it's on the HHS page, or it might be publicemergency.org. Historically, in previous pandemics that the US has been through, that's the way it's been done, is every 90 days, and a new executive order for a public health emergency is a 90-day time frame. The last time that the Trump administration extended the public health emergency was in January, right before the inauguration of the Biden administration, and they extended the public health emergency to April of 2021, and that was under Alex Azar. When the Trump or the Biden administration came in, they said that their intent was to continue the public health emergency through the end of 2021. And we had an acting Secretary of Health and Human Services that said that. Now, the confirmation period, if you follow politics, can take a while sometimes. So it wasn't until March 18th of 2021 that Xavier Becerra was confirmed as the Secretary of Health and Human Services. And that's his picture there. In less than a month after he was confirmed, he did extend the public health emergency another 90 days, as is historically done. So the public health emergency here in the United States at the federal level currently ends at the end of July. So it still remains to be seen, will the Biden administration continue to do another 90 days and another 90 days until the end of 2021? We really don't know. The one thing that we do know is that the Biden administration has said that they will give 60 days notice before the public health emergency ends or sunsets. So if we get to May 31st and we haven't heard anything about, hey, in 60 days this is going to end, then they're probably going to extend it another 90 days. Just something to keep in your thoughts. So, and the reasons that I'm spending so much time talking about the federal public health emergency will become very clear in just a minute or two. So for reimbursement for telehealth and telemedicine services at the professions or clinical providers, doctors, nurses, physician assistants, all of those individuals are regulated at the state level. For Medicare, they pay for certain CPT codes or outpatient professional services for patients accessing care in rural counties and HIPSAs in rural census tracts. Now I'm going to show you next why that's, or how that's been removed. So think about it as conditions of payment, not regulations, but 4 conditions of payment that Medicare reimbursed for telehealth services prior to COVID. And then Medicaid, we will hear from Nichole at the Ohio Department of Medicaid about what Ohio Medicaid has done in the last couple of years around reimbursement for telehealth and COVID-19. I think I mentioned this earlier, but as of the spring of 2019, all 50 states in the United States and DC did offer some type of reimbursement for telehealth or telemedicine or both. They sometimes define the 2 terms differently. All right, so here's our 4 conditions for Medicare telehealth reimbursement. The patient, prior to COVID, had to be outside of a metropolitan statistical area. They had to be at a designated originating site, which is a clinical location in a healthcare site. The services had to be within a specific range of CPT codes, and the services had to be delivered by an eligible practitioner. So the first two, the rurality and being in a clinical site, those are waived, can still continue to be waived during the federal public health emergency for Medicare. That's why that public health emergency is so important. The services, the CPT code range, remember we added, or Medicare added about 80 codes that are still part of the waivers for COVID that are dependent upon the federal emergency still being in place. And those eligible practitioners expanding to speech language pathology, occupational therapy, and physical therapy are all dependent upon those federal public health emergencies. So prior to COVID, this website here, this datawarehouse.hrsa.gov site, is where clinicians or billers and coders or whoever in your organization would go to find out if your patient could be seen via telehealth and if the provider would be reimbursed if the patient is a Medicare beneficiary. So this doesn't really matter right now. It's waived during this public national pandemic or this public health emergency. The way you find out if a code is on that certain list of CPT codes is to look for the Medicare Learning Network Telehealth Fact Sheet. Here's the link for it. This snippet on this slide is from 2020. I haven't checked in the last week or so, but I don't think that the 2021 version of this fact sheet is out yet. Again, this is something that when the administration changes in the White House, it takes a while to get all of the secretaries confirmed in the cabinet. So soon we should see this new 2021 version come out. This is just an example of what it looks like, an example of the services and the different codes, HCPCS codes or CPT codes that are eligible for telehealth reimbursement right now. When we talk about billing, this is as deep as I'm going to get on billing, but the patient site, sometimes when you read policy documents, it might be referred to as the rural site or the originating site or the spoke site. If you're reading Medicare documents or Medicaid documents or commercial payer documents, they might use different terms, but what they mean with any of those three is it's the patient site. On the provider site, reading policy, you could see it referred to as an urban site or a distant site or a hub site. If the patient is at a clinical facility, there's another facility fee that can be billed, and it's Q3014. It's only about $26, but is to recover the originating site's homing of the patient. So if a patient is at a emergency room and that clinical site is homing the patient, they can charge that $26 for rent and utilities of homing that patient. If the patient's at home, as happens normally in most telehealth visits right now, then you're not going to bill that because there are no costs associated with homing that patient. They're in their own house. On the provider side, for a telehealth visit, you bill the same CPT code as you would as if the patient and provider are in person. And then you use different modifiers. Now, this is different. Medicare has certain different modifiers that they use. Nichole will talk about Ohio Medicaid modifiers, and commercial insurance companies use different modifiers so that it changes dependent upon where the patient's insurance comes from. Back to that telehealth fact sheet. Last year's telehealth fact sheet came out on March 17th. Here's the link that was included in the fact sheet to the CMS website where all the frequently asked questions and fact sheets were located, and they're still out there. So every year I talked about in July, the proposed physician fee schedule comes out. Every December, the final physician fee schedule comes out. So we got an early holiday present last year. On December 1st, the final physician fee schedule came out for 2021. Normally this happens at the very end of December. So we got that information a lot sooner last year. Some key takeaways: of those 80 codes I mentioned from last spring, about 60 of them have been added to the full permanent list that are available during the public health emergency. So these particular codes, you see a lot of, behavioral health, home visits for established patients, all of these types of things. Now, then the other codes, many of the other codes of those 80 codes were added to what's called a Medicare Category 3 list. So these codes will only be reimbursed through the end of the calendar year that the PHE concludes. So this again is one of the reasons I've been harping on the public health emergency and when is it going to end, because it specifically affects Medicare reimbursement and what codes they will reimburse for via telehealth. So these are additional codes that are similar to the previous slide in category, but longer time of service, more detailed codes. So right now, because the public health emergency is in 2021, we know that these codes will be available at least until the end of 2021. After that, we don't know. Once we get to July and see the proposed physician's fee schedule for 2022, we'll have a better idea of what's going to happen. Also, we're not really going to talk about bills and legislative events, but there are many bills that have been through the state legislatures to extend some of the COVID waivers. And at the federal level, there are many bills that are currently before Congress to extend or make permanent some of the waivers that we've been talking about that have happened during COVID from Medicare beneficiaries. Now, we talked a little bit about audio only, and when we talked about the 80 codes, CMS has indicated they will not continue those audio only codes after the public health emergency ends. But they did add a new code, a new HCPCS code G2252 on an interim basis during the public health emergency. So if you are doing audio only codes, I would encourage you, or audio only visits, I should say, I encourage you to bill with this G2252, so then that gets into the database of claims that Medicare looks at, and they can analyze that and see what does the future look like for audio only. Is it really reimbursable as a telehealth code or not? All right. As of, I mentioned fact sheets before, CCHP did put together a fact sheet about the finalized physician fee schedules, also available on their website at this link. They do, for legislation regulation, they do a national map, and you can see this, where you see both the red and the teal lines is where there's both jurisdictions with bills and registers. So most of the country has a lot of legislation going on right now around telehealth. The only state that is exempt, or territory that is exempt from this, is Puerto Rico. Every 6 months for the past 10 years or so, the National Policy Center has put together a 50-state guide of the different Medicaid programs across the country. They recently redid their website, so now you can come to their policy finder page and click on a specific state and see what's going on with the bills and the status of the bills in any individual state. And this is what, it looks like this map. Now, as far as commercial or private payer insurance, they do have a map for that. Click on one of the states and it'll tell you what the parity laws are in the state. States usually have parity for either coverage or payment. And there was also Foley and Lardner is one of the well-recognized law firms in the area of telehealth. They put together a really interesting guide of commercial insurance laws that came out in February of this year. And this is just a snapshot from that. So if you're into policy, interesting reading. All right, so that is my presentation on Medicare. Are there any questions about Medicare telehealth reimbursement before we turn things over to Nichole? All right, I am not seeing any questions. So I finished right on time. It is now time for Nichole. If you want to go ahead and open up your audio and video and share your presentation. As I've talked about Nichole today, she is from the Ohio Medicaid, part of the Department of Health for the state of Ohio. And we are so welcome to have you. Nichole is my go-to if I've got Medicaid questions for Ohio, and she's always been there for us. So we're very happy to have you here with us today.
Thank you, Becky. Good morning, everyone. I'm Nichole Small. I work for the Ohio Department of Medicaid. I'm in our Bureau of Health Plan Policy. So I work on our telehealth policy as well as other general policies related to Medicaid providers. So just to provide a history of where our policy has been, and we'll talk about where it is now. In 2014 is when the Department of Medicaid actually implemented its first telehealth policy. So it was at that time called telemedicine. It was really limited to psychiatric services, evaluation and management services provided by usually a physician level practitioners. So it was pretty limited. It was a hub and spoke model. The patient still had to present to an eligible originating site, which could be a physician's office, an FQHC, a rural health center. So it was very strict in that sense. And the patient had to also be at least 5 miles away from the practitioner who was delivering the service. So in between that time, we worked with stakeholders, and in July 2019, we actually adopted an expanded policy. So this significantly expanded the types of practitioners and services that were eligible for telehealth. We allowed patients to be at their home or at a school as a patient location, so they no longer had to actually present to, an eligible originating site. So they could be pretty much anywhere and receive a telehealth service. So we also loosened up restrictions on the practitioner site location, so the practitioner could have more flexibility in where they were physically located. So in our initial telemedicine policy, we did have restrictions on where the practitioner could actually be. So shortly after we implemented that policy in 2019, COVID hit in March, and so we had to act quickly to get some emergency rules implemented. And so we did this through Governor DeWine signed executive orders that allowed us to implement an even further expanded telehealth policy through executive order. And so those rules are effective for 120 days. So they're short term, and we ended up filing several of them, which I'll go over, but just to make sure that we could expand services while people were, being told to stay at home and cancel elective surgeries and things like that. So it was a really significant shift in how people were accessing care, not going into the doctor's office and things like that. So we really had to act quickly to get it expanded to where people could still access services given the restrictions with COVID. So then, after the emergency rules, we actually followed it up with the formal rule filing process. So that's what we call, it's a permanent rule in the sense that it's effective for longer than 120 days. So I'll talk about that policy as well. So just to talk about our definition of telehealth, we define it as the delivery of healthcare services to a patient related to diagnosis, treatment, and management of a condition. So prior to COVID, we defined it as this top bullet here. So telehealth is the interaction. It's synchronous, interactive, real-time, patient and practitioner are talking, live communication. So it's not a recording or a picture sent in. So with COVID, we actually expanded that to include this second bullet here. telephone calls. That was really important in the rural areas of the state where broadband access isn't widely accessible. And so we allowed that, which was helpful, especially also for the elderly population who aren't as familiar or comfortable with technology, to still be able to access services from eligible providers. So we also included some remote patient monitoring services. There are a few procedure codes that we do cover for that. And then also patient communication through secure portals. So through the electronic health record, if there's some communication back and forth with the patient, that could be considered telehealth. And so the definition for telehealth was really changed from telemedicine to telehealth because telehealth is a lot broader. So our initial policy was called telemedicine because it was really focused on, physician level services. And then we expanded it. We adopted telehealth is what we call our policy because it's more broad. It includes practitioners that are not just physician services. It includes behavioral health and a lot of other services. So here's a list of the emergency provisions that we put in place to respond to COVID in March. So we implemented our first emergency rule March 20th. So that, really expanded the practitioner types. We modified the definition of telehealth, which I just went over. We removed some restrictions. We added a originating site fee, which we had in our initial policy, but had since removed it. So we did bring that back to allow for some assistance during this time as providers are pivoting to integrating telehealth into their workflows. So we did that. And then, so like I said, with the emergency rules and executive order, these rules are only effective for 120 days. That's why you'll see, the 2 lines below, we have 2 more rules that we filed just to make sure that there were no breaks in the services that were available through telehealth. So these were just kind of the administrative behind the scenes, what we had to do to make sure that we could enable practices and practitioners to continue delivering services through telehealth. And then the last line is our permanent rule that we filed in November. So it was effective November 15th. Again, lined it up so that we didn't have any breaks in coverage of our policy. So this is our permanent rule, just in the sense that it goes beyond 120 days. So in Ohio, we're required to review all of our policies at least every 5 years. So if we do change the policy before then, it would go through a formal rule filing process where the public is involved and there's opportunity for public comment and feedback. So, so that would not change until we review it in 2025 or before then, which I think we do plan after public health emergency orders are lifted. We'll revise the policy in kind of a post-COVID world, but that's not something we're actively doing. It's just something that's planned for the future. So for now, this policy is what's in effect, the policy that was effective in November 15th. So our vision and goals for telehealth, really, it's a balancing act. No one has unlimited resources. So we, top of mind, want to maintain quality of care, making sure that patients can get access to services, improving health outcomes, and then providing flexibility for providers and patients. So at the beginning of the public health emergency, things were a little chaotic, and providers and patients alike were trying to get their bearings and accessing services and providing services. So really, we took all of those things into consideration when developing the policy that we adopted. So just some highlights of what we did. We expanded telehealth services to include more eligible medical services and medical practitioners, and behavioral health practitioners. So we also eased the technology restrictions on the patient and practitioner interaction. So similar to what Becky mentioned with HIPAA, we looked to the guidance that was provided by the Office for Civil Rights as far as the flexibilities for HIPAA under the public health emergency. So that's where we allowed, non-public facing platforms could be used to deliver a telehealth service. So we also issued telehealth billing guidelines. Obviously, there's every payer kind of does things differently. So with all of our, going back to 2014, we have resources available to help providers understand how telehealth should be billed. So the procedure codes, the modifiers, if you're, an FQHC or an RHC, if you're certain types of providers, there's instructions to help guide providers along. So we also included pharmacists. So those practitioners as of January 17th of this year are able to provide services not only through telehealth, but also in person. So that was a new provider type that we added this year. And so we also added them as eligible telehealth providers, and they can do medication management and some other services. We also expanded nursing facility care, hospice, and home health services. So certain components of those can be done through telehealth. Obviously, not every aspect of nursing facility care or hospice or home health can be done through telehealth, but we did allow, if there's any components that can be provided through telehealth, then it could be that we allowed that. So there are certain services that we opened up for those provider types to allow for more flexibility in service delivery. So just a list of the providers that we expanded. So this isn't an all-inclusive list. This is just kind of what we've expanded beyond what we had before the public health emergency. So specifically in response to COVID, we added the skilled therapies, audiology, occupational therapy, physical therapists, and speech language pathologists. So that was a big one. We heard, especially from our Medicaid school program providers, as far as services that they often deliver through telehealth. So we did add those practitioners as eligible providers to deliver telehealth services. We also have individuals that hold a conditional license. I think this is for speech language. So if they're just working on their license, they're not quite fully licensed yet, they can still provide telehealth services. The Medicaid school program practitioners, dietitians. We also have behavioral health practitioners and trainees. So these are the supervised individuals that work under supervision of a licensed individual. So a licensed independent practitioner can provide telehealth services, but also the individuals that work below them under supervision, the trainees, assistants, interns, if they have that certification in Ohio, they're actually able to also deliver telehealth services. So that was big in especially access to care. As we know, there's challenges in enough behavioral health services and practitioners. So this really expanded the access to services as far as having more practitioners eligible to provide the service, the behavioral health services, than it was helped with access to those services. We also added dentists. So that was in response to a House bill. It's really limited as far as dentists and optometrists, the services that they can provide through telehealth. I don't know if anyone on the call is a dentist or optometrist, but we do have information in our billing guidelines about that. But we do get some questions of like, how can you do dental through telehealth? So it is amazing what the technology does these days. And then, like I mentioned, private duty nursing and home health and hospice agencies. So those were all added as eligible providers that could bill or provide services through telehealth. So to go along with that, we added different eligible services. So this, again, isn't an all-inclusive list. This is just what we've added specifically in response to COVID. So the remote evaluation of recorded video or images. So this would be the communication through the secure patient portal, things like that, virtual check-ins, online E&M services, remote patient monitoring. So we did look a lot to Medicare and what they were covering for telehealth when we worked on our policy and where to expand it. So a lot of those, I think Medicare also covered. So we looked to that, and then we also added the skilled therapy services like audiology, speech language, and physical and occupational therapy. So we allowed, the dietitian, since we added them, we added the medical nutrition services that they provide, as well as lactation counseling provided by a dietitian. So those services could all be provided through telehealth under our emergency rules, and then our rule that we filed in November of 2020. So all of these services are in addition to what we had already covered for telehealth. It's just too many to put on the slide, but just to give you an idea of what the expansion looked like specifically in response to COVID. So there are a lot of other services that are covered, but I just wanted to highlight what has been done in response to COVID. So we did get a lot of stakeholder feedback. So we have a pretty good network of providers that we work with and stakeholders. We've been working with Becky and the UMTRC on telehealth for several years. So we have participated in different work groups, and we have a great pool of stakeholders that we get feedback from. And so they were really helpful in this process of what would be helpful from their end. So we did get a lot of feedback from providers. Obviously, providers were interested in this delivery mechanism. So we took to heart and listened to what providers were experiencing in the field and the challenges they were having to shape our policy to alleviate some of the pain points. So we did see, a skyrocketing number of services that were delivered. So the claims that we received, not a lot of providers were delivering services through telehealth before COVID. So this kind of really forced a lot of providers to quickly adopt that into their workflows. But we did see a significant increase in the telehealth claims that we did get after we adopted these policies. So just to give you an idea, and I know this information is outdated, but it just kind of highlights the shift of how many claims we had before. So as far as mental health and addiction services, there were 4,000 claims on average before March of 2020, and then 270,000 claims just a month later in April. So we saw, especially on the behavioral health side, that's where we see most of the telehealth utilization. So we saw a significant jump in the number of claims that were being submitted for telehealth. So we do have a lot of telehealth resources. So this is a link to the rules. So these are, if you're a policy person like me, you can read the rules. These are the administrative code rules that outline the specifics of what providers are eligible and services and kind of the legal speak and whatnot. So those are the actual rules and filings that give all the information of why we did different things and what was changed and that sort of thing. So we also have billing guidelines. So that's the second link here. So depending on the date of service, we have billing guidelines to correspond with each policy that we've adopted. So with COVID, we have the updated billing guidelines that correlate to the policies that we put in place. So that's a really helpful resource, and we updated it throughout, over time. As we learned more and had a lot of questions, we would add some clarification and things like that to the guides. So I would say that is that would be a great resource if you're an Ohio Medicaid provider and you're billing. It lists, all of the procedure codes. It tells you what modifiers to use. We do use the modifier GT primarily to identify telehealth services. So that's a great resource. There's some other documents there that we developed to help providers. So if you have any questions on how to bill, that would be the link to go to. So those have been pretty helpful for providers. We've gotten a lot of feedback that it's been beneficial in their practice. And I think this is my last slide. So happy to take any questions if there are any.
Thank you so much, Nichole. I wanted to go back to a couple of the different populations that you've opened up to, specifically school providers and lactation. Which one do you want to talk about first?
We can do school.
Okay. So is what I have read in your list here for Medicaid school program practitioners, can you just expand upon that and how that's going to work?
Sure. So we have in the Medicaid school program, there are behavioral health practitioners that often work with schools, whether that's on site or an off-site provider coming in. We do in Ohio have some school-based health programs where there is actually a healthcare provider that shares the campus with the school. So the Medicaid school program specifically is for those individuals, the children that have an individualized education program. So these are the services that are identified to help with their learning. And so that's what I mean when I talk about the Medicaid school program. So those services and children that have an IEP can also receive telehealth services through that program. So there are also occupational therapists and physical therapists, those skilled therapists that also work in the school setting. So by adding all of these practitioners, it allowed for more.
That's awesome. If a child does not have an IEP, then they are not eligible for telehealth.
They're not eligible under the Medicaid school program. So the school wouldn't be covered under the Medicaid school program, but they could be covered under the regular telehealth policy. So if there's another Medicaid provider that the school is working with to see patients that have an IEP or don't have an IEP, the Medicaid school program is really limited to those individuals with an IEP, but kids that don't have one can still receive telehealth services. So allowing that place of service opened it up. So if there's outside practitioners that work with schools.
So this change allows for the schools to bill that facility fee, is that correct, on behalf of the student?
Yeah, so they bill, I'm kind of not super involved in the billing, but they do bill for procedure codes, and the school under this, they actually pay the state share, and then we claim the federal match funding. So, and then they submit cost reports and all that. I'm not super familiar with cost reports, but I know they do that every year.
That's awesome. There aren't many states that allow the school to get reimbursed for providing that service. And I mean, every little bit helps, for the schools to have a nurse on staff or some other person on staff there.
Yeah, it's definitely, I know Nationwide Children's, they're a big Medicaid, they work with a lot of schools, not just the Medicaid school program itself, but, for all students. And we do have some pretty impressive school-based health providers in Ohio that are working, not just with the school-age children, but the communities, and they're open to everyone, not just the kids at the school. So the families can go there, and it's a lot easier as far as access and transportation barriers are kind of broken down at that point. Yeah.
Absolutely. I do have a question here. So I just want to say kudos. I'm excited that the lactation has been opened up. I think that as a mom that had breastfeeding issues, if I could have had a telehealth visit, that would have been awesome. Okay, so we got a question here. Has there been any discussion on the type of telemedicine devices home health agencies can utilize, since they have only recently been allowed to care for patients with telehealth?
We don't prescribe what type of devices that are used. We kind of leave that open to the provider. There's so many different platforms. There's, and since we allow telephone calls, it could just be a phone call to the patient to go over different things or provide a behavioral health service. So we're not very prescriptive on the service or the platform. It just has to meet these certain parameters. So it leaves a lot of flexibility for providers. I know that there are some providers that do remote patient monitoring, and they have the devices and things like that. So it's left purposefully vague so that the provider can, as long as it meets those parameters, then it can be a telehealth service.
Okay. A comment, Shane from the State Office of Rural Health is on with us. He said that they are working to provide some school-based health center training and learning opportunities in the near future. So thanks, Shane. That's great to know.
Awesome. And I know there is a school-based health training kit or resource kit on the Department of Education website. And then also we're doing some maternal and infant support program work where we have, I think, some stakeholder meetings coming up, and I can share that with you, Becky, where we are further expanding, or we're proposing to expand lactation counseling to additional practitioners. And there's other services and programs within that umbrella of the maternal and infant support programs. So that could also be considered potentially in the future for telehealth as well.
Absolutely. Yeah. Anything that you've got, send it over.
Sure. Thank you.
All right. Any additional questions for Nichole before we break for lunch? Got one here. Where can we find information regarding funding for a school-based program? I'm going to ask you to contact, to go on, I'm going to show you on our website here. Hang on just a second.
And I can even send you the toolkit that the Department of Education has. I know the Department of Medicaid and some other agencies worked on putting it together as a resource for schools as you're considering, adopting a school-based health program, kind of how you can engage funding opportunities in the community and things like that. So there is some information, I believe, in there. I can send you that.
Great. Yeah, if you'll send that over, we'll send that out to everyone. Also on the UMTRC website, we do have a grants section that is specifically geared towards anyone that wants to write a grant for purchase of telehealth equipment, those types of things. And I will put that link in the chat as well under resources and grant resources. Okay. Somebody was asking what was DME. DME is
durable medical equipment.
Yeah, and the question was, can telemedicine devices be DME? I'm not sure I understand the question.
Well, right now we don't, in our state plan, I don't think, and I'm not the DME expert, but as far as what I know, we don't cover a lot of those devices. So the remote patient monitoring, as far as in the stakeholder meetings that we've been in, we kind of see it as like a whole other animal other than telehealth, because it involves the device and then the reading of the information that's generated from the device. So we cover the procedure codes for the service of the monitoring and whatnot, but right now I don't think we have a lot of those, like the Bluetooth scales and things like that. I don't think we have a lot of those covered in our regular state plan for telehealth services, but I think under a lot of our waivers, those things can be covered. And then in the future, I know we'd like to adopt, as remote patient monitoring is becoming more widely available and it's shown to be effective. I think that that's kind of the natural progression of our policy would we eventually want to include something about remote patient monitoring, so that there's a lot of different policy questions that come to mind when developing that sort of what that would look like.
Yeah, that's another area. I definitely applaud your efforts in that. Not many states have taken up remote patient monitoring as something that they're looking at. So thank you.
Yeah, it's very interesting what providers are doing today that we hear from. So it's really, really neat.
All right. Well, I don't see any other questions. It is 12 o'clock Eastern, so let's go ahead and take a break, and we'll come back after lunch at 1 p.m. Thank you. Thanks, Nichole.
Thank you.
Welcome back, everyone. Thanks for coming back after lunch. I hope you enjoyed a little bit of respite while we were taking a break here today. It's beautiful outside, so definitely try and get some fresh air today and some sunshine. We're going to start off with financial sustainability this afternoon, and we'll be joined later today by Cody, Mullen, and Cameron Hilt to talk about behavioral health. And then we'll finish off the afternoon with talking about with telehealth with patients at home, and a little bit more about what's the difference between seeing a patient in person versus via telehealth when they're patients at a clinical setting, and then other accommodations for when the patient's at home and may not have access to any digital peripherals for pulse or blood pressure, those types of things. And then we'll have an open opportunity to do some role play this afternoon where individuals can volunteer to either operate as or to play a role of a patient or a provider, and let us critique their backgrounds, how they make eye contact, those types of things. And then we'll finish off by 4 o'clock this afternoon. So without further ado, I'm going to go ahead and share my screen. All right. So our topic starting off this afternoon is financial sustainability. Again, I'm Becky Sanders, Program Director of the Upper Midwest Telehealth Resource Center, and thank you for joining us today. So we talked this morning about community health needs assessments and telehealth champions, and we looked at how to incorporate telehealth into your workplace. So kind of thinking back again about the needs assessment we talked about with the workforce and incorporating telehealth into your organization, let's talk a little bit more about assessment questions. So when you look at your patient base from your community health needs assessment or any other documentation that you have, ask yourself these questions. What does or do or what do I or what does my organization want to accomplish with a telehealth program? So there are many things that you can do via telehealth. You can do virtual visits, you can do med checks, disease management, patient safety checks, behavioral health assessments, and many more things. So what specialty tools do you really need? Our example this morning in the work plan was for behavioral health because that is the most simple to do. It's just a conversation. We don't need blood pressures. We don't need temperatures. We don't need to palpate parts of the body, anything like that. But if we did, then that would be an additional cost, and we'd have to have additional resources to start up that type of a service line. The other question you or your organization needs to ask is, how many virtual visits do you want to do each month? Do you, as a provider, want to only do virtual visits? Do you want to do some inpatient and some in-person and some virtually? Is the goal for the individual provider, or is the goal for a team of providers in a single organization? And then, have you ever asked your patients what they would think about a virtual visit? All right, so talking about platforms, electronic health platforms we mentioned this morning, and we all probably know this, are expensive. Do you have one of those platforms that does have a video module that is available for it? Does it make sense to spend the money to invest in that module? Maybe yes, maybe no. It just depends on upon your organization. There are other video conferencing platforms out there that are relatively inexpensive. And while it may not allow you to document directly into your EMR during the patient visit over a different platform, then you might be taking HL7 data and transferring that to your electronic medical record. You might be creating a PDF and importing that into your electronic medical record. There's a lot of variety and a lot of different ways to do this. Another question is, what education needs do patients have? So this morning I mentioned the top 3 diseases in the United States: diabetes, COPD, and CHF. What kind of educational programs could you offer your patients via weekly webinars or videos that you place on YouTube or Vimeo or inside your own website in a patient portal? There's a lot of variety of ways that you can disseminate information to your patients. And as far as education and engagement go with COVID and the public health emergency, everything has changed. Not only the delivery of healthcare that we've been focusing on today, but so many parts of our lives have been thrown topsy-turvy. There were very few organizations that were really invested in telehealth before COVID. Luke and I experienced that firsthand and with the tsunami of interest in telehealth in March and April of last year, as we saw in our technical assistance visits this morning. So what is the best way to educate your patients? Is there any special training that your staff offers that could be done via telehealth? And even more importantly, how do you motivate your providers to jump on this bandwagon and get this done? We looked at hem, haw, sniff, and scurry, and sometimes you don't have your providers might not have the vision or the technical savvy or the will to see patients differently than how they've been seeing them in person. So again, you might have to start with those providers that are interested in providing services via telehealth. Let the others sit back and see how it goes, and maybe they'll join in, or maybe they'll retire. Who knows? So telehealth is not a get-rich scheme. You and your organization, your providers are not going to get rich, but you need to make it financially sustainable, because telehealth does increase access to healthcare, and it can improve health outcomes, and it can reduce healthcare costs. So we talked about this a little bit this morning. Again, tracking savings. So reductions in no-show, provider mileage saved, patient mileage saved. We talked about those reductions in 30-day readmissions. And, even if you decide that all of your clinical practices your employees are going to work from home, then maybe you're saving utility costs as well. I mean, every organization, every clinic is just a little bit different. So we talked this morning about keeping your patients local. And what does that mean to ancillary labs, x-rays, MRI images, those types of things? And what happens to your local economy in a rural area if the patient stays local and the family is able to come and visit the patient at the local hospital? What additional revenues through shopping, through restaurants, the gift shop at the hospital, what additional revenues might be available to your organization by keeping your patients local whenever it's clinically documented that it's a viable option? So again, those lower no-show rates, and I was speaking with a group of community mental health centers last week, and they talked about the percentage of no-show rates and how their no-show rates went down dramatically during COVID because the patients were able to be seen via telehealth. They had a patient that was talking about being able to be home and being able to cook dinner and have dinner cooking on the stove, but still able to make that appointment, where instead of delaying dinner and having to run errands all over the place, that they were able to be at home and be more comfortable. Psychiatric patients or behavioral health patients also often say that they feel more comfortable sharing with their behavioral health professionals when they're at home and they feel like they're in a safe space. There's so many examples. The providers not driving to rural locations. We see this mostly in specialty arenas like cardiology or neurology, where a physician or other provider might go out and to do rural rotations in rural areas instead of having their patients come in for follow-up visits in an urban center. And all of that less driving on both the patient side and the provider side helps improve the carbon footprint across our country. So there are several different models that Medicare has dipped their toes into that kind of rethink the way healthcare is provided to patients. And most of these examples that I'm going to give you are based on trying to reduce the healthcare spend in our country. There is a documentary, if you like to watch documentaries, called, oh shoot, it's got the word fire in it. I'll think of it and I'll put up the link out on our chat. But it talks about how expensive healthcare is in the United States particularly. And one of the physicians that they interview for the video or for the documentary talks about what she gets reimbursed for if for a office visit versus putting a stent in a patient, and how there's another gentleman that talks about he's been in the military and is on all kinds of drugs, and how he felt like they were just pushing prescription pills on him to solve all of his problems. So there's a lot of different reasons why we might want to change the way healthcare is provided into more something based around patient-centered medical homes or accountable care organizations, or even looking at things from a population health standpoint. Many of the organizations that we work with are part of accountable care organizations, so providing services via telehealth is one of the things that is asked of them to participate in those programs. And then if you've been around healthcare for a number of years, you probably remember, I think it was 2012, when Medicare started asking more urban centers to do bundling payment, like for hip replacements or knee replacements. So if the hospital had a patient that came in for a knee replacement and they said it was going to cost, I don't know, $10,000, and that $10,000 that the hospital got reimbursed that for doing that knee replacement surgery, but that also had to cover the individual's physical therapy follow-up, any x-ray follow-up, and any pre-op. So the more efficient the healthcare organization was with how they used the funds that they got reimbursed for that surgery, the better off they were in the end. So it's these types of things that CMS has been looking at over the past, 8 to 10 years. I want to share with you some perspective about telehealth in healthcare systems and why I believe that it's so important to be used and incorporated into your organization's healthcare mission. So telehealth increases access to healthcare. We have definitely seen this before COVID, but even more drastically during COVID. If a patient has mobility issues or transportation issues and can be seen from home, then their access to healthcare is increased significantly by participating in telehealth events when they're at home. So they can have easier access to clinical services, and remote hospitals can provide emergency and intensive care services. Part of our national consortium of telehealth resource centers is every 6 months we go and do a strategic planning meeting and one of the 14 telehealth resource centers hosts that for us. Prior to COVID, one time we were in Missouri and we were on site at Mercy Hospital in Missouri, and the entire hospital was virtual. So all of these clinicians came to work every day in this hospital, but there were no patients at the hospital. They only saw patients remotely. So it's a totally different way of looking at things. Their patients, and this is pre-COVID, so their patients were at other hospitals. And Mercy is the hub that provides services to other hospitals that might not have as many specialists or might be in rural areas. But it really, it was very interesting to see that dichotomy of how healthcare was provided out of their organization. Telehealth improves healthcare outcomes by patients getting in to see a provider earlier. Then they were saving healthcare spend later on. And some of those, there are data studies out there about that. Some of that is a little bit more difficult to postulate, but think about the example of a patient or a kiddo at school that's got an earache. If we diagnose that the kiddo has an ear infection and we get that treated with antibiotics early on, then the kiddo's never going to end up in the ER with a burst eardrum. Same thing with a cancer patient. The earlier cancer is caught, the better the possible outcome for that patient and the less expensive outcome for that patient. There are statistics around tele-ICUs and stroke patients and so stroke patients for neurology, cardiac patients for cardiology, that show telehealth programs in those instances save both brain and heart muscle and lower the amount of time that the patient's in the hospital and lower their chance of further infections and poor outcomes. Telehealth can reduce those healthcare costs. I just talked about that, and it can assist in addressing shortages. There have been many workforce studies over the past several years, and in some instances, the data shows that strictly based on population size to a specific number of patients per practitioner, a state might have the appropriate number of practitioners. One study in the state of Indiana showed that for dentists. But when you look at the location of the patient and the location of the dentists, it didn't match up. There were many more dentists available in urban areas and less in rural areas. And the rural patients did not have access to dentists the way a patient in an urban area would. Additional things that telehealth can assist with is it can support clinical education programs, just like we're doing today. I would love to be in Columbus or Findlay or Toledo or Cincinnati or Dayton talking with you all, but right now this is the best we can do. Hopefully that will open up and fairly soon we'll be able to have in-person events again. And this goes for the same thing with diabetes self-management education or education for lactation or some of the other specialties that we've talked about today. As far as organizational productivity, we talked about using lean healthcare methodologies or Six Sigma methodologies to reduce waste in our healthcare systems. And again, those are only two that I'm familiar with. There are Kaizens and all kinds of other methodologies about reducing waste. But the more efficient that we can be with our clinical providers and their time, the better off our healthcare system is going to be. So here are some of those percentages I was talking about. For home monitoring of chronic diseases, that can reduce hospital visits by as much as 50% and keep the patients stable. National averages for readmissions to hospitals within 30 days following a heart failure episode is 20%. Implementing a telehealth monitoring program can reduce that to less than 4%. For stroke patients, the ability with a telestroke program can reverse the consequences of a stroke have risen from 15% to 85%, so 85% chance of reducing stroke. And in EICUs, telehealth programs can reduce mortality by 15 to 30%. So I've spent most of my time today already. I'm not going to play this video, but if you have ever seen the movie Field of Dreams, Kevin Costner plays the son of a minor league baseball player that never got to go to the major leagues. He owned a farm, and the farm was hurting for money, and the bank was looking to repossess the farm. And he spent money and time and energy creating a baseball field because he had a dream about it. And after he did create that, the baseball players did come. So sometimes patients don't know what they need until we provide it for them. Just something to think about. And I hope that when we do our interactive role play this afternoon, you'll be able to share more stories and talk about what you've seen over the past year. This data here is from fairhealth.org. Ran across them about a year ago, and they really provide some interesting snapshots and data analysis for what has gone on with telehealth services and claim lines in the last year or so during COVID. I got to listen to a presentation, I think it was about a month ago, from their president. And one of the things that she pointed out that I hadn't noticed yet was that in every single chart, you're going to see this 99213. So this is an established patient office or other outpatient visit. So an established patient, typically a 15-minute office visit, accomplished via telehealth. So in March of 2019, that's there in fourth place, the fourth most popular CPT or HCPCS code. In March of 2020, at the beginning of the pandemic, it's in first place. So we see that as we go through these different snapshots that I want to show you today. This particular snapshot is from March of 2020, so it compares data from claim lines that are Medicare claim lines and many private payer claim lines. I've chosen the Midwest section of the country, so all of these states you see here and those in green in the graphic are represented here, and we're looking backwards, March of 2020 over March of 2019. And here we see that the percentage of claim lines grew in that March 2020 back to March 2019 timeframe, 2,841%. We can also see the top 5 diagnoses compared year over year. Mental health conditions is first at 37.61% in 2019, and again 45.4%, an increase in 2020. And this, I find this very interesting as well. Here we're comparing urban claim lines to rural claim lines. So in 2019, there was a slight uptick in rural claim lines over urban claim lines. But now, under the COVID waivers in March of 2020, you see that there's much greater usage of telehealth in urban areas than rural areas. And that's really changing the way that CMS is thinking about telehealth. And that's all due to the Medicare waiver of the patient being in a rural area and being at a clinical facility. All right, now looking at November of 2020. So later in the year, last year, again, we see that 99213 CPT code in fourth place in November of 2019, and in November of 2020, it is in second place. Again, we're looking at just the Midwest right now with this information. Here we see a percentage change, 4,618% increase in telehealth claim lines. Again, mental health is the top diagnoses, and increase from 32.9% in November of 2019 to 54.37% in November of 2020. And then again, we're looking at a Midwest snapshot. And again, the difference in those claim lines, urban versus rural, they're pretty much the same in November of 2019, but a drastic increase for urban claim lines versus rural in November of 2020. This is the whole country. I won't spend time going through all of the statistics, but again, you see over 4,000% increase in telehealth claim lines, 99213 showing up on both charts respectively, and mental health conditions, and the same kind of thing, urban versus rural claim lines. So that's March of 2020 for the entire nation. November 2020 for the entire nation. Again, we see 99213 here and here. 2,937% increase in claim lines. Here we see acute respiratory when you include the entire nation, higher than behavioral health or mental health conditions in November of 19, but definitely a huge increase in mental health conditions in November of 2020. And again, similar information, urban versus rural in 2020. All right, so do we have any questions about financial sustainability of telehealth programs before we move on to our next topic? All right. We're going to go ahead and move on to our next topic. And we actually have two speakers. It didn't make the agenda, but Cody Mullen and Cameron Hilt are going to be speaking today about behavioral health and or telebehavioral health as it's listed on our agenda. Cody and Cam, you guys want to go ahead and share whoever's sharing their screen and go ahead and get started today?
Did I do that right, Becky?
Yep, looks great.
Okay.
I'll let you guys introduce yourselves.
Sure. So my name's Cameron Hilt, and as Becky said, we're going to take a little bit of time to talk to you about our Crossroads Partnership for Telehealth, which is a telehealth network that's focused on, one of the focuses is providing telebehavioral health services in rural counties across the state of Indiana. So I'm also co-presenting with Dr. Cody Mullen. So I'll go ahead and let Cody introduce himself real quick, and then I'll take it over from there.
So good afternoon, everyone. It's a pleasure to join you. My name is Cody Mullen. I'm a senior advisor with the Indiana Rural Health Association. I was the past project director for the Crossroads project that we're about ready to present on. I also serve as the principal investigator of the Healthy Start Communities That Care initiative here with the association. And recently transitioned, I'm now at Purdue University as a clinical associate professor in the Department of Public Health, where I am the director of their new Masters of Health Administration program. I also serve as an adjunct faculty member at IU University's Fairbanks School of Public Health. I currently serve as the president of the ARC of Indiana's Board of Directors. I share all this, and Cam's going to share his background just to show the biases that we bring to our presentation of the experiences that we've had thus far.
And then as I said before, my name is Cameron Hilt, and so I currently serve as the program director for Crossroads Partnership for Telehealth. I also work as a data and evaluation coordinator for the Upper Midwest Telehealth Resource Center and the Community Paramedicine Program. Before coming to the Indiana Rural Health Association, I worked as a population health analyst with a population health consulting firm. So that's just a little bit about me, just as Cody said, just to show a little bit of our background before diving in. So just a couple quick disclosures. Any program that's mentioned in this presentation is funded through the Health Resources and Services Administration. We have no conflict of interest, and our product is supported by the Federal Office of Rural Health Policy, HRSA, the U.S. Department of Health and Human Services, under that current grant number. So anything that we say in this presentation is coming directly from us, not directly from any of these other bodies. So Crossroads Partnership for Telehealth is a program that is offered by the Indiana Rural Health Association, whose mission is really to improve the health of Hoosiers living in rural areas. And we do this through leadership, education, advocacy, collaboration, and resource development. And really where this fits into the Indiana Rural Health Association through the Crossroads Partnership for Telehealth is when you look at the state of Indiana, we really see that there's a huge need and lack of access for behavioral health services. So if you look at the map to the left, these areas that are shaded in blue are areas that ultimately lack mental health professionals in order to offer these services in these counties. And so when you're looking at this map, you can see that some of the larger cities in Indiana are not colored blue, but several rural counties across the state ultimately lack those resources. This is especially important in Indiana, as nearly 1/5, 19.5% of Indiana adults are going to experience a depressive disorder at some point in their life. And 63% of the state is located in a health professional shortage area. So really how Crossroads is built to help meet this need in Indiana is by developing and maintaining a telehealth network that will increase access to behavioral health care services in rural communities and conduct evaluations of patient utilization. The evaluations and the data that will be collected through this program is ultimately going to be utilized to help grow the evidence base for assessing the effectiveness of telebehavioral health care services for patients, providers, and payers. So in order to do this, first for our network, we needed to identify hospitals that we could partner with for this project. And those hospitals would be located in geographically and culturally disparate rural counties across the state of Indiana. And a part of our being a part of this network is being provided telebehavioral health equipment, such as medical carts, tablets, and HIPAA compliant video conferencing systems that will allow these hospitals that are a part of the network to begin conducting these virtual appointments with patients. And then lastly, with each one of these partners, we are actively receiving data so that we can then measure the effectiveness and utilization of the appointments. And we're also utilizing evidence-based instruments in order to collect that data as well. So we're receiving that on a frequent basis in order to be able to evaluate that effectiveness. So we currently have 5 different partner sites, and each one of these sites is a little bit different as far as where they are offering these services within the sites. So the first partner I'll talk about is Reid Health, which has one site that they're providing these behavioral health services, which is in their behavioral health outpatient center. Gibson General Hospital has 2 sites. They're utilizing these services through their ambulatory care clinics. Perry County Memorial Hospital has 1 site, and they're utilizing it through their emergency department. Davies Community Hospital is utilizing through their emergency department. And lastly, Virtual Consult MD has 2 sites, and they are utilizing it through their behavioral health clinics. And so when we were identifying these partners, really we wanted to ask a few questions in order to see that this program was going to be the right fit for them. And so one of those questions being, what behavioral health services currently exist in your community and your target population? With the map that we just referenced earlier, you can see that there are a lot of areas where these services are not being offered. And so we wanted to first see that this was meeting a need for that partner in their community. Secondly, it was asking, would your organization benefit from telebehavioral health services? So is this something that makes sense for your organization from a business standpoint? Is this something that helps meet the needs of those patients and better improve their health outcomes long-term? And then lastly, what concerns or questions do you have regarding implementation of a telebehavioral health service? And so really, it can be really intimidating to implement a new service line, or it may be difficult to keep that service line going after you've already started it. So really trying to kind of troubleshoot how we can help not only bring these telehealth services to these areas for a few years, but how can we help maintain these services long after these grant funding, this grant funding may end. And so really, we want to give you a quick overview of some of the equipment that our partners are using. And so, as we said before, these are kind of being utilized in a variety of different environments. So either through ambulatory services, the emergency department, some are utilizing it through more like welcoming environments. Each one's in a welcoming environment, but some may have more dedicated space to be able to provide those services. Others may have to utilize a medical cart in order to be able to wheel and utilize the service wherever best fits for that patient. And as with anything related to telehealth, it's incredibly important that we have reliable and efficient Wi-Fi for any of those services that are being delivered. The main medical carts that are being utilized by our partners are the Jocko and American Will. We'll show you an example of what those medical carts look like here shortly. And the typical devices where the patient and the behavioral health provider are interacting, it's typically through a tablet, laptop, computer, or television. So this is an example of one of the Jocko medical carts. So as you can see, it has wheels and it can easily be carted around to any room where a behavioral health consultation would need to be set up. So within those carts, they have the capability in order to make sure that that tablet that's attached to it is continually charged. And really to make it very simple as far as prepping it for the patient, making sure that it's that upkeep is simple, and to make it ultimately less burdensome for the personnel that's operating the equipment, which should typically be clinical staff, provider, or clerical staff. So here's just a couple different examples where you can see that these medical carts are being utilized. So whenever a patient is identified as needing those behavioral health services, those carts are just being brought in for that patient to be able to directly interact with that behavioral health provider in whatever room they may be. And then here's just a couple examples of these more private spaces that are being provided in order to interact with those patients if the dedicated space is ultimately something that that partner or hospital is able to provide. And with that, I'll go ahead and hand it off to Cody.
Thank you, Cam. So as Cam mentioned, equipment is very important, but also the software that we utilize is very important as well. And there's a lot of different security concerns to keep in mind. There we go. So video conferencing applications, now that we are about 15 months into the pandemic, we all probably have Zoom fatigue, Teams fatigue, WebEx fatigue, whatever video conferencing of choice that you want to choose. So when we first started our project, we utilized Zoom, and for a lot of our partners, that was the first time they ever had the ability to utilize Zoom. And we were really making sure to educate them on the utilization of that software. But as time has gone on, Zoom is now a verb, kind of like Kleenex. We're Zooming, but it could be a lot of different platforms that you could be using. So I think it's important as you're considering at your host organization of implementing a telebehavioral health program of what solutions do you currently have that your staff may already be familiar with. If you're already a Zoom shop, then ensuring that you can have a HIPAA compliant option for Zoom is very beneficial. But you may be a Skype or Teams shop, a WebEx shop, a video shop. We have one partner that they like video, VIDYO, which has a better connection than Zoom. and less delay when their counselors are speaking with the patients. But when you look at, as you look at that, you really need to consider the safety, especially in behavioral health. Not only do you have HIPAA, but you have 42 CFR Part 2 and Part 3 to keep in mind around the security and the safety for all those devices, both within your practice, but then also once the information leaves on the internet connection at your facility. So it's very good to make sure your devices are locked. So all the iPads that we use in our grant have a passcode associated with them that the IT or IS department can utilize, as well as the clinical team. And then also disabling all other settings possible. So an iPad is a computer now. It can do a lot of things. So we made sure to go to great lengths that the only thing that iPad is able to do without the passcode is utilize a Zoom connection. And once that Zoom connection is started, the patient cannot end it. The staff has to come back and enter a passcode in a parental lock take feature and be able to end that talk. So those are just some things to keep in mind as you're looking at this. We had one practice at one time, they utilized the medical assistant's laptop in the delivery of the telehealth services, but they had to make sure they logged completely out of the EMR every time they left the room, so the patient did not click around and get into the EMR. So that's another thing to keep in mind as you're choosing your solution. And then lastly, training is vitally important. We recognize that any change in the processes for any staff is a difficult change, and training is important, and we can never overtrain on that. So our training, we really broke down into three main categories when we thought about that. So first off was around our equipment. So we recognized that there were several generational differences in the utilization of the technology that we were utilizing. For some, an iOS or a tablet-based interface was new to them. So some of the simple trainings were, where's the volume? Where's the mute? Where's the on and off button? For other staff, though, they have 4, 5, 6 iPads at home for their children or for themselves to utilize. So that training we went directly into about the HIPAA compliance and the security specifically for this application of that tool. So we recognized that one training was not sufficient. So we created step-by-step instructional manuals from how to turn the device on to how the patient interacts to the daily care that needs to be done, that we left on each cart that was laminated and safety pinned or zip tied, excuse me, onto the cart so they were not lost. We also did random evaluations, or the IT department, each clinical setting did, to ensure that there's the proper usage of the equipment. We did have one site, they were not utilizing our equipment, but it was an iPad Pro with a Bose speaker that the clinical staff put Netflix on. So at lunchtime, they had a cart to watch Netflix with very high sound quality. So just ensuring that the equipment is being utilized the way it was supposed to be utilized, and that everything is working the way we want. So how we did that was staff meetings. So we would go on site and spend a day and a whole shift. So see one, train, learn one, do one. It was kind of our model. So we would show them how to do one. We would then do one with a patient while they watched. And then we would step out of the room for the third patient and let them do it. And then we'd be in the building all day. So if they had questions, they knew they could quickly come and ask. We recognize that when staff hit a burden or an issue with the equipment, that equipment then sat dormant for a long period of time. So we could rapidly overcome that concern. And then we did monthly meetings after that initial training to ensure that they were comfortable with it. And then also is a good opportunity, if you're familiar with technology, updates seem to come at the most inconvenient times. So it's a good opportunity to check the equipment, to ensure that it was doing the automatic updates that were turned on, and if not, to ensure to train the staff on the importance of ensuring those updates, because many of them were there for security purposes. So the next part of our conversation this afternoon that I want to share about is around billing and the reimbursement for these services. And then lastly, we're going to get into clinical measures and evaluations and understanding if this program is working. So telemedicine, the model that a lot of our sites are utilizing is an originating site and a distant site. This has gone a lot more fuzzy as we have entered into the public health emergency, or the PHE, because originally the originating site, or where the patient is located at, had a very set list of what those were. So it could be a rural health clinic, It could be a hospital. It could be another kind of clinic. But with a public health emergency, the federal government recognized, and state governments as well, that a lot of patients do not need to go into the clinic, especially if they're coming in for a non-communicable disease. We didn't want to necessarily expose them to COVID-19 or other communicable disease. So the originating site can now be a patient's home. And I know, for example, personally, last week, I, at this very desk, had 3 doctor visits back to back to back using Zoom, and it was very convenient and very easy. Prior to that, I would go to my primary care office. So that's the originating site or the rural site. As Becky said at the end of her last presentation, we have seen that shift now that more urban is using telehealth than rural. So I think it's important as we are recovering from COVID-19, as it enters our rearview mirror, how do we see the change of the utilization of telehealth? And then our distance site, that is where the specialist is, or that is where the clinician who's providing the service is. The facility is able to bill a fee at the originating site for the offering of that room and the services there, and then the professional fee is billed from that distant site. So the originating site, some of this language is older. So this is pre-public health emergency, so I left it in here. So you can see if we ever went back to non-public health emergency, and there's a lot of legislation currently being discussed at federal and state levels about ensuring that we don't go all the way back to this, but these are the sites that were included as an originating site that were located in a metropolitan, outside of a metropolitan statistical area, an MSA, and was located in a rural HIPSA or health professional shortage. Well, those were physician and practitioner offices, it was hospitals, critical access hospitals, rural health clinics, federally qualified health centers, skilled nursing facilities, community mental health centers. So a lot of different clinical settings that that patient could come in to do. And when they did come in, and still we have some partners right now that are still acting as a originating site, they bill a HCPCS code of Q3014, where they're reimbursed, and it's roughly $20. I don't know the exact numbers in 2021, but roughly $20, and that is to allow for that MA to check them in, take them to their room, turn on the technology, and allow them the opportunity to speak with their provider. That distance site practitioner, though, there are a list of eligible services for that as well. For our area, it generally was around physicians, nurse practitioners, and physician assistants who are in the psychiatric realm, who are able to prescribe medication to aid in individuals and patients, as well as clinical psychologists and clinical social workers. Majority of the visits we have seen over our 3 years of being a project have primarily been around what I would classify as traditional talk therapy with a psychologist or social worker. So these are individuals that come in for various talk therapy supports and are not seeking a medication or qualify for a medication intervention on behalf of their behavioral health needs. Where that differs is we have one site in Richmond, Indiana, and Fayette County and Connersville, Indiana, where they utilize the technology both for the talk therapy, but then also for medication-assisted treatment, or MAT, for individuals with a substance misuse or substance use disorder, where you have someone who has a DATA 2000 waiver through SAMHSA and HHS and DEA to provide those services as well. So if you are a distance site, as some of the graphs that Becky showed again at that 1 to 130 session, showing changes over time, you do build a CPT code, a clinical procedure terminology, or a HCPCS code. And in addition, you will have your point of service as a 02 telehealth. And if you're billing under the optional payment method 2, then you need to add the GT modifier. And I'm sure you've learned throughout today, moving on, the wonderful resources of the Upper Midwest Telehealth Resource Center and Becky's team, and they're here to support you when you get to that level. But I just want to introduce these topics and ideas to you so you can have them in the back of your head as you're starting to build this program of what billing do we need and services. These are currently the approved HCPCS CPT codes. This is just a smattering. It's actually about 4 PDF pages of codes, but there are various codes, and several psychotherapy and pharmaceutical management codes related to behavioral health services are approved services around behavioral health. Now you might be thinking, okay, that's great, Cody and Cam. We're not looking at necessarily doing that distance hub model. We really want to bring in the provider and have behavioral health services be part of our primary care setting. And maybe you're executing right now under a patient-centered medical home or PCMH or an accountable care organization, ACO. And there's various different mechanisms out there at the federal level and state level that encourages this collaboration in that primary care setting. One model I briefly want to touch on just to kind of spur some thoughts in your heads is the collaborative care model, or COCM. So you might have heard of CCM, the chronic care management. So this collaborative care model is very similar to that, only it's specific around psychiatric diagnosis and behavioral health needs. So in a psychiatric collaborative care model, or COCM, it's a team approach where you have 3 individuals who are at the table. You have the primary care provider. This could be an MDDO, but also could be a nurse practitioner, physician assistant. They're the leader of the team. So it is based at the primary care setting where that primary care provider is the leader. They also have within their staff a trained behavioral health care manager within the PCP's office that's able to have that continuous relationship with the patient. And then lastly, there's a psychiatric consultant who has the ability to prescribe medications, who is also involved as the third arm of this team. I think it's really important here that this is someone who can prescribe medications. So a psychologist or a social worker or other therapist would not qualify in this model. You'd really need someone who has that prescribing authority and has a continuous relationship with the primary care team. And this relationship can come in the form of telehealth. Especially out in rural or underserved communities, we recognize psychiatrists are not everywhere. It would be amazing if they were, but we recognize that this is probably one of the most underserved specialties coming out of medical school right now. I know IU, I know I probably shouldn't say that on an Ohio call, but IU Med School has one of the biggest graduating classes a few years ago. Of their 300 graduates, 2 are going into psychiatry residencies. So it's a greatly underserved area that is a requirement for this model. And in this model, the behavioral health care manager must have, like I said, that formal education or specialized training in behavioral health care. This could be a social worker, this could be someone in nursing, this could be someone in a psychology. They also have a continuous relationship with the beneficiary, so the patient who is within that COCM model, and then collaborative integrated relationship with the care team. But not be a member of the primary care's clinical staff. And case management or care management can be provided both face-to-face or remotely. So in this idea that the primary care provider would have a panel of patients who would identify needs by the primary care's diagnostic standards to need psychiatric involvement. That could be a telehealth visit in a hub spoke model, as we discussed before, that could engage with that patient, but it might be where that primary care provider is comfortable with prescribing the medications themselves, but they want someone with more specialties to help inform and educate them on what the right utilizations would be for the situation. So the patient's able to come in, they would have this social worker, nursing, or psychology case manager, either remotely or face-to-face. So this could be via telehealth. And then that team meets and says the patient may not be responding well to the medication, or maybe responding amazingly to the medication, and have those adjustments as well. This then pays on the back end on a PMPM, so a per member per month reimbursement fee to the primary care provider. So the primary care provider has that contract with that psychiatrist. They are able to then reimburse them at whatever negotiated rate they have on top of any visits that they had directly with the patients. And then in addition, this then incentivizes and covers the cost of this collaborative care. So again, just another idea that I really want to keep you guys thinking of as you're looking at how do I implement behavioral health care. And we're going to try to leave 15-20 minutes for question and answer as well, because I'd love to have some discussion over this. But if you're like, how do I integrate this into my practice? It doesn't always have to be that hub spoke model. You can start small, especially if your providers are willing to do that. The last payment slide and then the policy guide will be quiet and get back to some more clinical information is MACRA. So MACRA came out in 2015, and it's hard to believe it's been 6 years ago. So this is the Medicare Access and CHIP Reauthorization Act, and it had 3 main goals. It was to end the SGR, sustainable growth rate. is make a new framework for rewarding healthcare providers for giving better care, not just more care. It was combining existing quality reporting programs into one new program. And this is where we hear MIPS and APMs if you're in the practice world. MACRA is the legislation that created those two programs. But under MACRA and since MACRA and the ACA, we have seen a lot of new payment models being spearheaded and targeted around the different parts of our country. For example, at the national level, CHART, which is a new payment mechanism for rural hospitals, is currently being tested, accountable care organizations. So I'd encourage you, reach out to the TRC, ask me questions at the end, or you can find me on the IRHA website or Cameron as well. As new models come out, there's unique ways that you can implement telebehavioral healthcare. There's not one size fits all. So be thinking not only about the technology and the software and the training your staff needs to be successful with the actual brass tacks of delivering the care, but the sustainability model behind the scenes. There's a lot of different avenues depending on what you're trying to achieve. So the next area I want to go over is screening tools. So the Crossroads Partnership for Telehealth, as Cam mentioned at the beginning, we are trying to build an evidence base behind, is telebehavioral health a successful delivery mechanism for behavioral health care throughout rural parts of Indiana for our grant. So there's a lot of different ways that we can measure changes in behavioral health care, both through screenings and assessments. I want to spend a few minutes to discuss those, but also be thinking, since I joined later in the day, I'm not sure who all is on the call, but if you are in that quality assurance, quality improvement role or hat, be thinking, how can we utilize patient-reported outcome data, not only to better inform the care that they receive in the clinical setting, but also to understand what's working well and what's not working well in a setting. So there's a couple of behavioral health setting screenings and assessments. There's the GAD-7 and the PHQ-9. So the PHQ-9 is 9 questions on a scale of 0 to 3, looking at various levels of exhibiting of depression over the last 2 weeks. So for our grant, every patient is requested on every visit to complete this quick 9-question questionnaire. And there's a lot of literature out there, more than I can ever share with you in an hour, nor do you want to hear the policy guy understand clinical literature. It might be a good laugh if you're a clinician, right? But there's certain avenues. So some of our patients do this on the iPad when it comes in. It opens to the PHQ-9. They can complete it utilizing the EMR's web interface. So it goes right into their chart. Then when the psychiatrist, psychologist, LCSW gets on the call with them, they already have this data point and can react to it. And we'll talk in a minute about what the different levels mean. GAD-7 is a very similar measure tool. Similar to the PHQ-9, it's 7 questions on a scale of 0 to 3, and this time it was really focusing on the delivery or the measurement, excuse me, of potential anxiety. Pardon me, caught my words there. So when you're looking at the PHQ-9 or the GAD-7, there are a lot of different measures, and these could also be triggers for you of when do you know when to engage with your telehealth provider, when do you encourage that patient to go for a face-to-face visit, even if it involves a long drive, and when do you as a primary care provider are able to monitor the patient. So for the PHQ-9, it goes from none, 0 to 4, mild, so watchful waiting and repeat. Moderate is when there's indications of potential CBT and or pharmacotherapies being involved there. And then we go up at greater scales to moderately severe and severe. For anxiety, it just goes none, mild, moderate, and severe with the same threshold there at about 11 to 15. But there's also other questions your clinical team are going to have to be asking and considering. Could these symptoms have been triggered by some sort of other psychosocial stressor? We have seen a huge increase in our data of PHQ-9s that have been reported to us since the pandemic hit. We recognize that, stay at home, kids not going to school, loss of job, loss of sense of normalcy has caused a higher demand for the services that telebehavioral health services is able to provide. What is the duration of the current disturbance, and what treatment has the patient synced out for? What treatment is the patient willing to receive? Is there a history of similar episodes? Is this episodic, or is this an acute illness that needs an immediate intervention because it is out of the blue or maybe not normally defined within that patient's history. And then is there a family history of similar conditions? So really the thing to remember here on our grant, a score of 10 or more is really when the psychologist or someone who is not trained in medical pharmaceuticals, really at that point is when that MD needs to get involved, MP or PA needs to get involved to discuss the potentials of a pharmacotherapy engagement with that patient to treat those symptoms. And we recognize that this data is a little bit dated. This is pre-pandemic, but just to kind of put in perspective, all the way back in 2016, just what is the spread of this? So we recognize, starting over here in the green, that 1 in 4 or 23% of Americans have a serious mental illness, an SMI. And that is defined not as a mild depression or mild anxiety, but severe depression, severe anxiety, schizophrenic disorders, or other mental conditions. 18.3% have a mental illness as well right now. And then substance use disorder. I know I briefly mentioned that before about one of our providers trying medication and treatment, but recognizing the co-occurrence of substance use disorder as well as with mental illness. So we see this changing in substance use disorder from an illicit drug to a polystimulant to a synthetic drug change over time. And that's a whole nother presentation. Be happy to share some data during the Q&A if there are questions. But roughly 7.5% or 1 in 10 Americans has a substance use disorder, and they would be patients who would be a prime candidate to participate in a telemental health system there. And then roughly 3.4% of Americans, or 8.2 million individuals, have co-occurrence of both that substance use disorder and that mental illness. Again, this is 2016, so this is a little pre the opioid pandemic that really spiked in 2018, 2019. As you looked at the charts, we saw great improvements. And then some of those improvements have eroded since the pandemic hit. So again, something to keep in mind there. I also encourage you to be thinking as a provider community, when you want to get into the substance use disorder and screening and assessment area, there are a lot of different assessments, and we're going to go through a few of those. But SBIRT, so screening, brief intervention, and refer to treatment. This is a federal program that's funded through the SAMHSA, the Substance Abuse and Mental Health Services Administration. I apologize for all the acronyms, but healthcare is nothing but acronym soup. So in Indiana, IU is our partner. I'm not sure who the partner is in Ohio, but these are free resources very similar to a TRC setup that can come in and help you practice, understand some of the evidence best practices to implement a universal screening program. What are those brief interventions that you want to provide, and then how do you refer them out to treatment? We recognize, and I do not say this tongue in cheek, we do recognize that amongst our partners, the number one issue of why they choose not to screen every patient in either the primary care setting or even the behavioral health care setting for a substance use disorder is the lack of ability to have someone to refer to. There's a massive shortage, and that is where telehealth may be able to be a game changer for you. You do not necessarily, your clinicians don't have to have that fear of, uh-oh, I have now uncovered, I now have documented in the medical record that this patient has a substance use disorder, and I don't know what to do for this patient. You may now have the resources to say, do you mind staying an extra half hour? Can I bring in my nurse practitioner via telehealth, roll the cart right into that same exam room? If you have the ability to stay with the patient, be a part of that discussion. If not, do that warm handoff, walk out, and then come back in after that discussion and say, how did it go? What can I do to help you? What can I do to support you? So there's a lot of different screening tools out there. So just next step, so audit C. So when do we say, when do we think it's really important to make sure you engage with those? So if the audit scores of 14 or above, the DAT scores of 6 or above, further assessment is needing. And that is going to be a qualitative assessment as well, right? You need to ask the patients and have discussion with the patients about what really is going on out there. So there's, like I said, the opioid risk tool, there's the assist, there's the DUDIT, and the DUDIT is not specific to opioids, but can be used. We use the DUDIT C, which is the short form version in our grant. So this is an example of the opioid risk tool. So depending on your gender, if you're a female or a male, you go through and you check boxes of these things, and notice that there are different weightings depending on your gender for those. So for example, a family history of illicit drug use is a score of 2 for a female, but a score of 3 for a male. But then if you go down further, the history of pre-adolescent sexual abuse is much more an indicative indicator of potential opioid risk for a female than a male. So here, a score of 3 or lower is a low risk for future abuse, for opioid abuse. 4 to 7 is a moderate risk, and then 8 or higher is a high risk. So that may change the way your clinicians interact, or also for your primary care doctors to know which patients to refer into that behavioral health service via telehealth because of how limited the services may be. The assist, and I knew I put the acronym there because I know I would never remember it. So that's alcohol, smoking, and substance involvement screening test. This is recommended by the World Health Organization. It can be used in the SBIRT, that screening, brief intervention, and referral to treatment. This is NIDA has also modified this. So NIDA is a division of the NIH, or a subsector of the NIH. I don't know if division is the right word, but it has measures against all these different medications or substances one may use: cannabis, cocaine, inhalants, sedatives, street opioids, prescription opioids. And then based on scoring 0 to 3, 4 to 26, or 27 plus, depends on the best course of action for that patient and where to refer to. Got the hiccups, I apologize. Please don't unmute and try to scare me. So the DUDIT, this is the Drug Use Disorder Identification Test, or the DUDIT. It has a score of 11 items that scores up to 44. A score of 25 or higher is when there may be a probability of heavy dependence on drugs. So questions 1 through 9 are scored on a scale of 0 through 4, continuous. 10, 11 are 0 to 4, and then that is added up. I encourage you, though, a lot of these screening tools, the old way of doing them were on paper, and there's nothing wrong with paper. I have an addiction to printing things when I could not need to, but that does add a lot of time when you think of staff timing. So if you see a patient, you want them to do the depression, anxiety, and a drug use disorder or drug screening tool, there's 3 tools that then your nurse practitioner, your physician, one of your MAs, your nurses, whoever, will manually be scoring. So as you're utilizing technology, as you're utilizing iPads, iPads are relatively inexpensive now, $300-400. What happens if you would have an iPad in each exam room? So as the patient's doing it, these scores are already being done, as well as the interpretations being given to the provider. They scored a 20 on the PHQ-9, a strong indication for need for treatment through pharmacologicals or through traditional talk therapy. So last section I want to go over, and then I want to make sure we have plenty of time for questions and answers, is measurement tools. Measurement is a critical part of testing and implementing change. Measure tells a team whether the change they're making actually leads to improvement, and measurement for improvement should not be confused with measurement for research. This is a quote from the Institute for Healthcare Improvement, which is a group that Dr. Don Berwick started, which is one of my idols and mentors. So I'm a little biased, heavily biased. But as you're implementing one of these programs and you're looking at all these tools that we just went through, telehealth is a different modality of delivering care. It's a different way of giving care, and there's a lot of different measurements that need to be thought of. Not only do you need to make sure that patients are being cared for and they are happy with the treatment protocols that are being delivered for them, but you also want to make sure that your clinical staff and your support staff are able to do it. Physician burnout, provider burnout, healthcare burnout is a very popular topic right now. It's a very highly discussed topic before COVID-19, and then COVID-19 hit and the burnout was just amplified. And there's an interesting article that came out in Becker's earlier today about burnout, and we need to quit calling it burnout. We just need to restructure how we define healthcare and what we think is acceptable. But measurement's important, right? So how are we improving this? Does telehealth improve both patients and providers' perception of that overall care? But also measurement for improvement, measurement for information decision making by your team. That's not research measurement. That's a totally different kind of measurement. And if you try to do both with one, you'll fail at both. So you need to identify, if you want to do both measurements, you need to have 2 different measurement plans associated with that. So measurements, there's 3 types of measurements I want you to be thinking in mind. Outcome measurements, what are the outcomes of the patients? What are the outcomes of your staff? What are those process measures? Are you able to flip the room as quickly as you wanted to? Are you not having patients bounce back to your ED? I use a lot of examples from the outpatient care setting, but a lot of this can be applied to the ED. Patient comes in, you do a physical health workup, and you recognize there's no physical ailment at this time for emergent response, but the patient's in crisis. So you wheel the telehealth cart into the holding bay or private room or however your ED is set up while that patient's on that gurney, where they can have a discussion. Does that change the flow of your ED? Does it give your providers the ability to not feel like they have to treat a condition they're not fully trained to treat on? And lastly, what are those balance measures? What is the overall health of you guys, of your providers, of your staff, but then that overall balance and health of your community? And really, you get that measure out 3 times every 3 years when you do a community health needs assessment. That's a great opportunity to say, what is the prevalence of disease in my community, but also what are the perceptions of disease and what are the perceptions of conditions in my community that my practice may or may not be able to respond to. So with that, I got done about a minute or 2 before I thought I would. So I want to turn it over to questions and answers. Well, questions, I'm not sure I have answers, but at least questions or discussion to the group, and have some time that we can have some robust discussion.
All right, thank you guys so much. I appreciate the knowledge both of you bring to this topic. We've had a pretty quiet group today, so I am going to ask for questions in the Q&A, please. And you've got a wealth of knowledge here to answer any questions that you might have. So I'll start off with a policy question for Cody. So you spoke about MACRA again today. Since MACRA came out, I guess my work as telehealth has increased across the country, has taken me away from some of those reporting structures that came out of MACRA. What can you tell us about different numbers of groups across the country that are participating in MACRA, that are hitting those measures and reporting those?
So recent data, which would be really about 2019 data, because 2020 data just came in, so we're pre-pandemic, was showing that roughly 95-96% were getting either no change or bonus. So only about 5 to 10% of practitioners participating in MIPS, I should say specifically MIPS, were receiving a penalty. The practices that are doing the most success on it are the ones that are choosing measures that are on clinical pathways that they want to target already. So they may already be wanting to, and that's why I kept saying, if you want to be working on behavioral health needs, is there a MIPS measure? One measure is % of screening for depression in primary care visits. It's a hand-in-hand, glove-and-fit measure there that you're not doing duplicative work for one reporting program and one clinical program. We're also seeing a lot of accountable care, or APMs, advanced practice models, or payment models, pardon me. I've been out of this language for a few days too, APMs. And we're seeing some ACOs, very mixed outcomes. So some ACOs have been highly successful, highly rewarded. Others have been utter failures, just to be blunt. So CMS is still trying to figure out exactly what are the tenets that made the ones successful, and what are the tenets that made the ones not successful. Not to preview or plug too much, but there is the IRHA conference next month. And one of my presentations is the first 100 days of value-based care under Biden. So I'm working on that research right now, and we'll probably have a better answer. So if anyone can't come to French Lick, all the way over here in the Boilermaker, Hoosier State, let's shoot me an email, and happy to share that information with you as well.
Thanks, Cody. I don't think many of these people from Ohio are going to appreciate your comments about the boiler state. We might get some folks from the Cincinnati area that might want to come over to French Lick in the southwestern corner of Indiana. But so you're talking about the IRHA conference. All of us are employees of the Indiana Rural Health Association. So I have to plug the Ohio Rural Health Association conference that the State Office of Rural Health is assisting with, and that's in August, maybe the 9th through 11th, maybe, but I do believe it's still virtual.
Yeah, I think it might be the 10th or the 12th. I think it's a Monday through Tuesday, or Tuesday through Wednesday.
Yeah. So then I have to give a shameless plug to the July conference in South Bend, Indiana, which would maybe the northern people from Toledo or Findlay might want to drive over. That we'll be talking solely about telehealth, and that is available. I'll have Carolyn send out some links in our follow-up emails and surveys that we send out next week.
We did get a comment come in from Carl. He stated that home health agencies and their home health aides can be called telepresenters and obtain Ohio and federal approved certificates. They actually be providing hands-on telemedicine care for the patient due to COVID-19.
That is very encouraging.
Yes, it is. There's also the hospital at home model, which I know is getting more and more traction in the pandemic. And I think behavioral health and mental health be a ripe area for that type of model as well.
Yeah, and so my question then for Cam, we talked a lot about the current model of Crossroads, which is very much what I called this morning a business to business relationship. So it's a patient in a clinical environment to another clinical environment. But with COVID and all the waivers, so many more patients are seeking behavioral health treatment at home. And I can't remember where I heard the statistic, but somewhere someone said, or some article wrote, that nearly 50% of all of the telehealth visits over the last year during COVID were behavioral health visits. Do you have any comments on any of that?
Yeah, kind of. As Cody was saying before, it's so interesting to see just the impact that the COVID-19 pandemic has had on the mental health of individuals, and not being just located to a state, but all across the world. So really to see that there's just going to be more and more demand for these services in the future, as well as especially in some of these rural counties, there can be so much stigma surrounding mental health care. And so being able to receive those mental health visits in their own home. So it's not, hey, I drove past the clinic the other day, I saw your truck parked out there, like, why are you there? And even I'm originally from Evansville, Indiana, and we had basically one clinic that was for substance abuse disorder. So anyone knew someone was going to Brentwood, something wood. People knew immediately someone was getting care for substance abuse. And so for that, it removes that barrier for people being able to receive that care without the fear of the repercussions of their networks around them thinking any less of them. Now, granted, there is a lot of movement to the stigma around mental health becoming less prevalent, but there's still a long way to go. So being able to really receive that care within a patient's home is a huge leap for improving access for behavioral health services.
Yes, absolutely. Another comment in the chat, patients with COVID-19 often have underlying health conditions. And I have heard that as a statistic from the CDC, that the majority, I think 80% of the people who died with COVID-19 had other underlying health conditions. Will additional telemedicine care be authorized to care for these health conditions? Well, I hadn't really thought about that, but that is a very good question. I think now's the best time to advocate for additional services via telehealth. When Nichole spoke earlier this morning, or this afternoon, no, I'm sorry, this morning, of what's going on with Ohio Medicaid, they have opened up a lot of different specialties and disciplines and services under the umbrella of telehealth. And I think that now more than ever, the different things we're seeing in the state Medicaid programs and the different bills that are being introduced at the federal level, if there's ever a time for a telehealth bill to be to be passed, it's now. Question about home health aides being allowed to provide MAT services under supervision. Either one of you want to take that?
I think it depends on the MAT. Some MATs are classified as controlled substances. So depending, and I don't know Ohio law in Indiana, you must be an RN or higher to deliver a controlled substance. So home health aides generally are not. Some are, but generally they're more of a CNA or an LPN licensure. So there need to be a licensure change there, or changing of practice for that controlled substance.
Yeah.
I know that's also kind of like peer recovery specialists or community health workers, individuals that can build that natural trust with the patient, who have the lived experience to say, I know where you're at, and truly know where they're at. But the pharmaceutical industry is just concerned about the controlled substances.
Absolutely. And Carl, if you want to send that to me via email, I'll follow up with Nichole at the Ohio Medicaid and Shane at the Ohio State Office of Rural Health, and see if we can find an answer for you on that that's specific to Ohio.
I also know, so the GAO, Governmental Accountability Office, testified at Congress on Wednesday about the COVID-19 flexibilities and considerations for them in the future. And I forget which committee they were testifying in front of. It was on the Senate side. But if you're interested in that report too, I can also share that report with everyone.
Great. Yeah, if you would send it to Carolyn, we can make sure it gets out to everyone who registered. I was thinking of another question. Oh, I know. So we're talking about the increase in behavioral health services volume claim lines specific to this period under COVID. And we know that there was already a shortage of psychiatrists and psychologists anyway. The people or in organizations that are participating in the Crossroads Partnership for Telehealth, can you give us a sense of how many of them have hired their own psychiatrist or psychologist, and how many are working for a third-party vendor, or have contracted with a third-party vendor to bring in the specialties that they need?
3 are in-house. 1 has outsourced to a national group, and then 1 has outsourced to another partner of the grant to provide services within their ED. So it's a blend. We've had no one go live since the pandemic. Credentialing is a huge concern. It is not a quick process, especially with the national groups when they're credentialing at the state licensure board as well as the facilities board and payers. We're learning that on another grant right now for stroke care, half a year to do some of those things. So I think that's also an area where the collaborative care model, the COCM model I mentioned at the beginning or in the middle, the physician can prescribe the medication and just need a consultant, which changes some of the credentialing requirements, which can speed up and also allow your PCPs to practice at the top of their licensure. And really be engaged in the moderate mental health treatment.
Now, I don't remember the answer to this. I'm going to give Cam a plug next Wednesday at 1 p.m. He's going to talk about remote patient monitoring and chronic care management. I can't, those can be billed simultaneously, but I don't know with COCM if that can be billed with RPM.
I don't know about RPM. I know it can CCM.
Okay. So CCM and COCM can do it at the same time.
Yes.
Okay.
And the RPM would probably be, I don't know if can RPM be done for a mental health condition?
Yes.
Okay.
It can be done for an acute condition. I believe there's certain mental health conditions fall under that blanket. I think the main ones are substance use disorder and depression. I'm not aware of others outside of that. But
all right. Okay. Thinking of, my brain still keep going back to physician shortages, and I honestly don't know. There have been some residency grants available. state level, federal level. Cody, do you know, are those focused more on physicians? Would psychiatry or psychology fall under those as well?
Psychiatry would, so an MD/DO. Psychology probably not because it's a PhD or a PsyD. It's just really there's so few psychiatrists that the few out there don't want to do the management of a residency
Right.
because they want to be practicing. Maybe they don't want, maybe not that they don't want to, they don't have the ability when their patient load is so high. But I believe, I know the one at HRSA that came out for rural psychiatry was an option.
Okay. Yeah. All right. No easy answers on that one.
No, pandemic did not help us in this area. Some areas I think the pandemic did help advance technology and healthcare policy, but not mental health.
Yeah. Yeah, I'm surprised, and I don't know if it's the FDA approval process, but I'm surprised we haven't seen more devices for the consumer that are commercial grade and low priced to translate into, here's my data, my vitals data for a telehealth visit. So maybe it's in the works.
Maybe it was Walmart's recent purchase of, I forget who, it might happen.
Oh, yeah, I did see that. That was interesting. Yeah. All right. Well, thank you very much, gentlemen. I appreciate your time today very, very much. And we will forge on with our day. We're going to move to a more lighthearted topic. We've gotten deep in the weeds here. We're going to finish up the day with talking about telehealth and patients at home and some of the webside etiquette instead of bedside etiquette, and lighting and glare and backgrounds, all of that kind of stuff. And then hopefully we'll get some volunteers to do some role play for us.
Well, thank you. Have a great day.
Thank you.
Thank you.
Thanks, Kim. All right, so next up, we're going to jump right into telehealth with patients at home. And I apologize, my neighbors are mowing. All right. So when we talk about website etiquette, and I kind of created this term, and I've heard a lot of other people use it as well. But instead of a provider being at a patient's bedside in a hospital situation, we're talking about website etiquette, and it's different. And it takes time to get used to. Today I've tried, and sometimes I probably haven't done a very good job about looking directly into the camera in front of me and not necessarily my self view or my slides, because I've got two screens here. But you really have to be cognizant. You don't get as many body language cues on video conferencing because we just see a small snippet of the person that we're talking to. We don't see if I'm fidgeting with my hands down here, you might see my shoulders moving a little bit, but you can't tell what I'm doing with my hands. So it's very important for the provider to introduce themselves, check with the patient. We did some training last week with some genetic counselors and geneticists, and their organizations have asked them every time you go into a telemedicine visit or a telehealth visit or a virtual care visit to check with the patient, verify the patient's name and date of birth so you make sure that you've got the right patient in the room. That's important. You want to maintain that professional level, just as if the patient had come to you in an office. I've got my video camera, my webcam today set so you can see the logo on my shirt, but I do have logos on my ceiling in my background, or my wall in my background. I do not have anyone else around me. I'm in my home office today. I have made some changes. I've closed the blinds, and I've got a lamp that's a soft white light bouncing off the ceiling so that I don't have a lot of shadows on the side of my face. My door is closed and locked so that I'm free from distractions. Thinking about the genetic counselors, one of the genetic counselors shared that they were working with a patient, and all of a sudden there was a voice from the patient's side of the conversation. There was someone else with that patient, and it was okay. It was a spouse, but the genetic counselor definitely would have included the spouse in the conversation if they would have known that they were there or that the spouse was there. So you really have to take all of those things into consideration and think about asking those questions and trying to reduce distractions. And we'll talk a little bit more about that in a bit. All right, so some of the examples we saw from Cam and Cody about patients, you could tell that the patients were in a clinical setting, so something like an exam room, that type of thing. In that type of environment, you might not have a lot of control over the color of the walls or the tile or the color of the carpet on the floor. But really, in reality, especially when we talk about behavioral health, all we really need is a device and a webcam and broadband access, of course. So the things that you'll need for the patient really depend on, is the patient at home? Are they in a clinical setting? What's going on in the area around that patient? And I've talked about clinical education a couple of times today. So there are a lot of different options as far as clinical education rooms. And the size of those rooms and the equipment in those rooms really is going to depend on what type of education is being offered. What do you need to do to appropriately do that training? If you're talking about diabetes self-management training, maybe you want to have real or plastic fruit and vegetables, or a plate that shows the proportions of carbs to protein that a diabetic should be eating. So when we move that patient out of the clinical environment to home, there are some things that are kind of a given in a clinical environment that aren't necessarily a given in a home environment. And one of those things is privacy. You don't know if your patient at home has other people in the room unless you ask. If the patient shows up pushing a shopping cart down the aisle in a grocery store, it's a pretty good clue that they're not in a private environment. Or if they're in a car, hopefully they're not driving. Or if they're in a park, they might not have privacy. And that's definitely something that we want the patients to be in a safe and fairly private environment when they're sharing public health or their own private health information. And I spoke a little bit about website manner. Certainly, again, we've been using behavioral health throughout the day, so I'll continue with that analogy. But if you're discussing a very sensitive topic with a patient and they start to tear up, it's a lot harder to say, here's a virtual clinic tissue, instead of pushing a box of tissues across the desk at them. But there are other ways to empathize over video conferencing. Certainly facial expressions, and sometimes as a trainer, putting that hat on and thinking about what I do when I give presentations like this, one of the scariest things as a trainer or a presenter is silence. And sometimes silence matters. The tone of your voice matters. Using softer tones is more empathetic. Letting the patient have a moment to compose themselves with saying nothing matters. So those types of things. We'll get a little bit into consent and documentation. I'll show you some examples during this section of today's program. We'll also talk about vital signs and a little bit more about video etiquette as we finish up the day. So this is an example of a consent form for the patient to be seen via telehealth. I've heard, and there's a variety of ways to accomplish this. If you're seeing a patient for the first time, and right now, especially under the public health emergency waivers for COVID, you can verbally read your organization's consent form to the patient. They can verbally agree. You document that it was done verbally, and then you can snail mail, email, use a patient portal, whatever, to get that consent form to the patient, to get a wet signature and get it back into the file. Some organizations have chosen the thought process to say if the patient has consented to have a telemedicine appointment or a telehealth appointment, then they have consented. And we don't need the consent form because the consent was implied when they accepted the appointment. Other organizations have taken portions of consent forms and incorporated them into their annual HIPAA documentation that they require all the patients to complete. So there's a variety of different ways. Really, this is something for your legal department, legal counsel to advise you on. In the state of Ohio, Ohio has an executive order talking about informed consent, and that providers must document their use of telemedicine and meet minimal standards of care. And they go on to spell that out. You know, basically it's patient history, health history. Excuse me, this Ohio Administrative Code also talks about consent in general terms and nature, that the person making consent discloses the information. All questions asked about the procedure or procedures have been answered satisfactorily, and also that the patient must be in their right mind and must not be under the influence of alcohol, drugs, or lacking legal capacity, including the following here. The patient practitioner site must have access to the medical records of the patient for documentation, and then includes a clause about providing services according to the Health Insurance Privacy or Portability and Accountability Act, or HIPAA Act. The documentation standards go on about how the documents need to be maintained. So this is the patient record information. Each health care facility shall not disclose individual medical records except as provided by state and federal law. Have to systematically review the records, maintain adequate medical records, and have policies and procedures ensuring the confidentiality of patient medical records. And these records have to be kept at least 6 years from the date of discharge. That's assuming an inpatient setting. So there's all that information for you. I've talked a little bit today about the 14 telehealth resource centers and the the 12 regional telehealth resource centers around the country and the 2 national centers. The National Technology Center is known as TTAC, the National Telehealth Technology Assessment Resource Center. They have a lot of toolkits, a lot of videos. I've done a lot of great work talking about different types of technology and kind of the pros and cons of each one. Because we, as the UMTRC and TTAC as a national TRC, are federally funded, we have to remain vendor agnostic. So we are very careful in everything we do to say, you know, here are 3 different video conferencing platforms, or here are 3 different types of digital stethoscopes. And it is upon you as a provider or as an organization to do your due diligence in making sure that you pick the best technology or platform or whatever it happens to be for your individual organization and the services that you're going to provide. So here again, just some examples. These are, I try to always use at least 3 pictures for my examples to remain vendor agnostic, but the telehealth carts, the big old-fashioned carts that you push around, are starting to be a little bit more obsolete except for inpatient settings. And what we're starting to see in the field of home health we've talked about, or in community paramedics that Cam mentioned, is more mobile solutions, even in classroom settings. We've talked about that today as well. So this yellow case is an example of a travel medic kit. So this could be used in an ambulance and for community paramedicine. It could be used in an aid going, a home health aid going from house to house with multiple patients, the school-based setting, those types of things. This here is Taito, and this is a solution that some of the school programs use. I've seen that, and it has different attachments on the back to take heart or lung or skin, different cameras on the back. And this here is just an example of one monitor that has multiple things you could do. You can see pulse rate and pulse ox, blood pressure, EKG information, all of that on one monitor there. This example for taking vital signs is just a snapshot I pulled up on Amazon to buy a blood pressure cuff. And if you really think about it, when you talk about vital signs, so you go into a primary care office and they take your weight. So how many of you have a scale at home? I would guess that probably 95% of the country has a scale at home. Then they take your temperature, and I know thermometers flew off the shelves over the last 15 months or so. So I would guess that again, 95 to 100% of homes have thermometers. So a patient could take their own weight and orally tell the provider. They could take their own temperature at home and orally tell the provider their own blood pressure. Blood pressure cuffs on this example here run from $26 up to $71. I think most are around the the $25 to $35 to $40, which in most cases is not a big hardship. If you are in a household where there are medical professionals in the house, or you have individuals in the home that have high blood pressure, it's not out of the realm of possibility that there's a blood pressure cuff in the house. The other thing is the pulse oximeters, and they're again in about the same price range as a blood pressure cuff. And again, if you come from a medical background or you have providers in your household, you might have a pulse oximeter in your home as well. I have this one doctor's perspective that I want to share. I have recently taken my parents to multiple doctor's visits, and virtually over telehealth and in person. And one time when we were in person with a physician, he was talking about something, I can't remember how we got on the topic, but he was talking about taking his mother to an in-person visit. And his mother had said, or was complaining, that her doctor had diagnosed her without even touching her. And she was very upset about that. And my mother's doctor relayed that, you don't always have to touch someone to diagnose them. And if you watch someone stand up and walk across the room, or how they sit down into a chair or stand up out of a chair, or how they hold their posture, and just their facial expressions, that you can really tell a lot about a patient without laying hands on them. So that what I tell that story to bring back to you is, by paying attention to the facial expressions that you get when you're in a telehealth visit, you really can tell a lot of information. I did one presentation for a pain management group, and if there's anyone interested, I'm happy to share those resources. Old Dominion University created a series of videos that show the provider talking with a patient who is at home over telehealth, and the provider guiding the patient to do a self-exam to help extend the hands of the provider during that visit. So very interesting information and statistical, scientific look at how we can make this work. All right, so the last part of this that I want to talk about is just examples of what I call eye contact, the junk in your trunk, which is your background, and glare or lighting. So what we really want to implement in a telemedicine situation or a telehealth situation or a virtual care situation is a clean and uncluttered view between the camera that you're using and your own face. That is going to give us the best possible eye contact that you can make over a video conferencing platform. So if you think about it like getting your picture taken, like standing with a group of people for a group picture, you look at the camera, right? You don't look off in the background, or you don't look at the photographer's eyes. You look at the camera so that your eyes point to that camera. So hopefully everyone is looking at the camera, and when the picture comes out and you look at it, everyone is uniform in that. Well, and let me go back to that for a second. So I mentioned I've got two monitors here. I've tried to do a good job of only drinking or eating when I'm not on camera, because that's just rude. And any notes that I take, I have some desk space in front of my monitors here. I have taken care not to turn over here and start making notes on something. If I was a provider in the middle of a visit with a patient, the proper etiquette for me would be to say, okay, hang on a second, I need to make some notes. I'm going to come over here to my other monitor and tell the patient what you're doing, because you're looking over here and your voice is going here instead of here to my webcam and my microphone. Or if I'm looking down, you don't want to see just my forehead. Or over here, my face is muddled and my voice is or you see just the right side of my face and my voice is muddled because I'm talking down to this desk. And the patient or whoever is listening on the other end has no idea what I'm doing unless I tell you before I do it. So you have to think methodically about what you're doing as a provider to make sure that you can maintain that relationship with your patient over video conferencing. All right. As far as lighting goes, I'm going to stand up and make just a couple of changes to my lighting here, and want to let you see the difference in my environment. All right, so I have a hutch behind my monitors, and it's Alexa powered. I have a light up there, so I turned that off. I muted my sound because I found that when I do that, and others that also have Alexa devices, their devices do weird things too, trying to respond to my command.
Sorry, I don't know that.
See, she's confused. So now I have more shading over here on the side of my face, and if we were doing a dermatology appointment, you wouldn't be able to do a good assessment of my face. The next thing that I have done is to close my blinds. So especially in the morning, this light is very bright over here because the sun comes up this way. So now you can see that my face is very much more in the shadow. You can't hardly see it at all. So those two little things make a big difference in what you see as my face as far as lighting. So the light on top of the hutch is a craft light, and it's a gooseneck, and I just turn it up and let it do light off of the ceiling. I do not turn off do not turn on my overhead ceiling lights. I guess I could put a daylight bulb in it, but especially in a clinical situation, oftentimes those lights are fluorescents, and they're horrible at what they do to skin tones. I also don't want light behind me. I don't want to be backlit or haloed. I want the light to be in front of me. Alexa, video lights on. All right, so that's lighting. In this example here, we've got a woman who has a lot of light behind her, and it's very harsh light, so it's hard to focus on her face, to focus on what she's showing us. But just by changing that camera angle here, it's much easier to look at her, and you can actually start to not really make out the words, but see that there's writing on the paper that she's holding up. Another thing, just while I'm thinking about it, is I have Italian heritage, so I talk with my hands. But if I talk with my hands down here around my stomach, again, you just might see my shoulders moving. So that is something that I take time to think about, and it feels unnatural to me, just like looking in the camera feels unnatural, but it's something you learn to do so that whoever you're talking to on the other end doesn't miss your normal body language. I hope that makes sense. All right, back to lighting. So here is an example, a very poor example, where there's a lot of backlight. If this person would just close the blinds, it would probably be a lot better. It's a very professional background. He's definitely an educated individual, but the backlighting is kind of harsh. All right, so here's another shameless promotion for the UMTRC conference in July in South Bend, Indiana. We are going to be bringing a lot of equipment that we've purchased over the past year with some COVID funds we received, and allow people to play with them. And we'll have masks as giveaways. If you don't have a mask, we'll have hand sanitizer and all of that kind of stuff. We'll definitely be following COVID protocols and guidelines. But I want you to see the difference here. On these two photos on the left are the same light. The lights twist and come forward or backwards, and this one has a shelf to hold a device, but each of these lamps have, I don't know, maybe 12 or 15 different settings, so different hues and colors of light. So here, this lamp, that's a floor lamp, we've got it on a low setting, and here it's on a very high, harsh setting. So it's just interesting to look at different lights and think about how that affects the atmosphere of a room or a person's skin tone. Distractions, I've talked about that a little bit. I do have pets, and they are downstairs behind baby gates. I've got my door to my office closed and locked, and there's a sign on it, not to be disturbed. Same kind of thing, my devices are all muted. My phones are all muted and placed on do not disturb. I've closed my email so it's not dinging at me. I don't have reminders dinging at me. And that's all to be respectful to you, so that I am not distracted during our training sessions today. Background. So backgrounds are important. You've seen different backgrounds with all of the staff that have presented today. Several of us have used the blurring. Is anyone else having sound issues? My voice is doing that garbled thing again. All right, hang on. I will put on my headphones. All right, can you guys hear me now?
Yeah.
Okay, thank you. All right, sorry about that, guys. I can't even blame anyone else in my house for internet access issues. So we're talking about backgrounds. So in Zoom, there are lots of options for virtual backgrounds. I've got my blurred today, but if I took off my background, you can see my desk and my plants behind me. I could also turn on a virtual black background. We've created several for our organization that have icons behind us. I don't have a green screen behind me, so this is kind of weird. I don't like the pixelization that I get. There are green screens that you can buy if you just go to your favorite platform for like your favorite search engine on the internet and search for green screen. You'll see all kinds of things between screens that roll up, that attach to your chair, that take up a lot of space behind you. So there's lots of options out there about your background if you want to use a virtual background and don't want to use your traditional actual real background. So these two backgrounds here, or these three in these pictures, are really disheveled, and it's really not a very professional look for a background. So I really wouldn't recommend having all kinds of coffee station things behind you. But this pattern of these stumps is not too bad. It's, you know, it's not a bright, jarring color. It's kind of a neutral color. So when we start to talk about colors, we talk about wall colors, and what colors work best with skin tones. Usually a light blue or a light gray work well with all skin tones. So again, what I've been talking about during this section of our training today is really having a clean and uncluttered view of your environment around you when you're on a video conferencing call. External noises. So I've had some of those today. There's not a lot that we can do about those, or that I could do about those, unless I wanted to build a sound booth for my office. I suppose I could do that in my home, but usually the sounds are relatively quiet. But you might be in a healthcare setting where you seriously can't do anything. That's the only room you've got for a telemedicine visit. You might be beside a loud stairwell or a loud elevator, or near an entrance to the outside of the building. You might be in an urban area where there's lots of traffic. There's all types of things that might cause issues. Now, me using a headset, this is a gaming headset that wasn't very expensive, about $30 or $40, and it has an attached microphone, and the microphone has noise canceling properties to it. Before I was using the built-in microphone of my webcam. So you can try different things. You can purchase a standalone microphone to plug into your device that you're using. There's all kinds of speaker and audio options if that becomes an issue. And another thing to think about for acoustics, again, if you have control over your environment, is to think about putting drapes over your windows or using fabric that reduces sound. If you've ever been in an orchestra or a choir or a band, the practice rooms always have these fabric panels on the walls, and sometimes even on the ceilings. There might be carpet to help absorb sound on the floor as well. You can also buy sound dampening paint. Now, if any of you are home theater enthusiasts, you probably know all of this stuff. But just some examples. All right, so what's the future of telehealth? These are my two favorite quotes. The first one from Seema Verma last June during an interview when she was head of CMS under the Trump administration. She said that the genie is out of the bottle. So it is difficult to put a genie back in a bottle. And then my all-time favorite from February of this year, I was at a National Rural Health Association policy conference that was being held virtually. And their VP of Government Affairs and Policy, Carrie Cochran McLean, said, "The toothpaste is out of the tube." Now, I've had toddlers around in my house. I don't know about the rest of you, but if someone takes that tube of toothpaste and squeezes it from the middle and all of the toothpaste goes everywhere, it is impossible to put back in the tube. All right. So again, there is my contact information. I'm going to stop sharing so we can stop for questions. What questions do you guys have for us today? Yes, I got a question on the Q&A or in the chat. Pharmacies can now prescribe controlled and non-controlled drugs without an in-person visit in Ohio. Yes, that is true. Can home health aides do lab work like the collecting of gloves specimens for the patients? That I don't know. If you would send that to me via email, my email's on the slide deck, and I can put it into the chat as well. That one I'll have to research. So that's something that Cody and Cam touched on just a little bit with controlled substance prescribing. With all of the waivers and honestly before that, both in Ohio and in Indiana and in Michigan, I can tell you that the laws were changed so that a provider could meet a patient for the first time, take their health history, establish that relationship, and then prescribe controlled substances. Right now, the DEA, or the Drug Enforcement Agency, does have on its diversion control page the language that says that as long as the federal public health emergency is in place, providers can prescribe controlled substances on their first visit with a patient, and they don't have to have an in-person visit before that to be able to do so. So that is one thing. I don't know what the outcome is going to be at the federal level with the DEA after the public health emergency is over. It's definitely something to watch. All right. Any last questions today? Sounds like we're gonna end early today. I'm sure that's very disappointing for all of you. All right, so we will have a survey for you to fill out. You probably won't get it until via email Monday or Tuesday. We did record today's sessions, and I would say give us a week to get those recordings posted. If you want a copy of those slides, if you can wait until we get the videos recorded or the videos posted, we'll post the slides with the videos on the archived webinar portion of our website. If you need the slides before that, I will make sure that Carolyn gets them by the end of today. So don't ask for them today. You will not get them today, but we can get them out on Monday, early next week. Feel free to send, I put my email in the chat, bsanders@indianarha.org. Feel free to send us additional questions. I am going to do a shameless plug here with the work that we're doing with the State Office of Rural Health in Ohio. We do have several upcoming events. This today was just to kick it off and get everybody started with a really good basic understanding of telehealth. All right, so here's where we are today. Actually, it looks like we've put this one up twice. This is from our Policy Center, Center for Connected Health Policy. They're going to be talking about Medicaid policies on Monday. I'm sorry, that was today. Never mind, 21st. We'll be having virtual office hours next Tuesday, patient and provider resources. Cam, I mentioned, will be speaking on Wednesday about remote patient monitoring and chronic care management. And Thursday, Dina was speaking again about healthcare literacy and preparing patients for telehealth visits. That's something, and then what she'll be sharing is a lot of resources and infographics that we've created based on questions that we've gotten from folks like yourself. Later in June, we'll be talking about, I'll be doing a similar presentation to which I just finished about video conferencing presentation skills. We'll be talking about marketing your telehealth program and using remote patient monitoring to improve outcomes, and consent and documentation. You heard part of that today, but we'll be doing that again as it's a longer version of that on its own. So here's the link. I'll put that in the chat. All right. So thank you so much for joining us today, and I hope you have a great weekend. Take care.